Hi, good morning, everyone. Apologies for the delay. We're going to go ahead and get started this morning with our first session, Fireside Chat with Ambassador Satterfield. And we warmly welcome our co-hosts from ICRC, Fabrizio Carboni, the head of delegation for ICRC in the United States. I'm going to go ahead and turn it over to them. Ambassador Satterfield is right there on the screen. Thank you, everyone.
Thank you. Welcome, everyone, to the Baker Institute. I'm in London right now. Regret that I cannot be there in person, but I know this is going to be a very timely and a very interesting conversation. We're living at a moment of incredible global turmoil and instability. You can see it in the news, but the numbers are very striking. Today, the ICRC, the International Committee of the Red Cross, counts about 130 armed conflicts across the world, more than 6 times what was recorded just 26 years ago at the turn of the century. In some of these conflicts, we're seeing a crisis of compliance with the rules of war, according to the ICRC president. Well, we're here today to talk about what are the rules of war, why respect for rules matter for everyone, not just those living in war zones, and how they can help contain conflict and reduce suffering. I've seen this as my own career in the Middle East has brought me in and through many conflicts where the harm to civilians, the unnecessary exposure of innocent civilians to risk has produced not only human tragedy and suffering, as we have seen profoundly in Gaza and are seeing on a different scale in Lebanon today, but has also made resolution of those conflicts more difficult. We're going to speak in more depth about the challenges of protecting healthcare in armed conflict. What can be done to improve protections for hospitals, for medical staff in conflict zone? This is something that Fabrizio and I, Sonali, witnessed firsthand during the Gaza conflict, where very often those on the front lines, those most susceptible to harm and those harmed, in actuality, were workers for the ICRC, workers for UN entities who were trying to provide humanitarian assistance and medical care. We're going to end the day with a panel of frontline doctors who have worked to provide health care support to doctors in conflict zones, as well as providing medical care here in Houston. We'll end the day with a lunch and virtual reality experience organized by the ICRC, so audience members can see for themselves what it's like to live in a war zone. Now, I'm pleased to introduce my friend Fabrizio Carboni to help us kick off the day. Fabrizio serves as the chief representative of the International Committee of the Red Cross for the United States and Canada, bringing a wealth of experience and a deep commitment to humanitarian action. Prior to this assignment, Fabrizio was regional director for the ICRC's Middle East operations. With over 2 decades of field and headquarters experience at the ICRC, he led operations in some of the world's most complex emergencies, including Afghanistan, Myanmar, Lebanon, and throughout the broader Middle East. Throughout his career, Fabrizio has been at the forefront of efforts to uphold human dignity in conflict zones, promoting the laws of armed conflict and humanitarian action. His work has included ICRC efforts visiting places of detention to ensure humane treatment of detainees captured in conflict, advocating for the dignity and rights of displaced individuals, reuniting families separated by war, and fostering critical dialogue with both governmental and non-governmental actors on the conduct of hostilities. So Fabrizio, if I may, let me start off with a fundamental question. Can you help us understand what are the rules of war? What are the laws of armed conflict, the so-called LOACs, or the international humanitarian laws? Why are they important? How do they work?
In 5 minutes. Okay, I'll try to do that. Look, I think there is 2 concepts we need to understand when we think about conflict. There is a body of law on when can you use force. When are you allowed to use force it's the UN Charter, and there you have a series of circumstances where you're allowed to use force. The law of armed conflict is how you will use force, and doesn't take a position on the legality or not of the use of force. Okay, and I think it's a very important concept to separate both. And I think it's even important when you analyze, a political situation, because often people conflate the two body of law. In other words, people would say, my cause is just, so the use of force is legitimate, therefore I can use whatever means of war I have at disposal. And actually these are two distinct and different concepts. The law of armed conflict is actually what put limits to how you use force. But it's not, sometimes you hear, especially lately, that this is a kind of tree-hugger body of law. Not at all. This is a body of law which tries to find the balance between military necessity and protection of people who don't take any more part into conflict. And it is this balance which is really challenging in this body of law. There are a couple of rules which are clear. You don't execute prisoners, you don't torture prisoners, you provide healthcare to wounded. I mean, there are very clear rules, but then you have some issues around what is the proportionate use of force? What is precaution? What kind of weapons are allowed to be used in the battlefield? So it's on one hand a very simple body of law because it's really basic. It's really about basic humanity. And at the same time, it's complex because you have to reconcile military necessity with the protection dimension of the law of armed conflict. If you ignore one part of this body of law, I don't think you make justice to the law of armed conflict today. So this is, in a nutshell, I would say, what is the law of armed conflict today. And you find it, obviously, in the Geneva Convention, which is the most common body of law, which was adopted after the Second World War, which is, again, showing that this body of law is not adopted or developed in some obscure room in Geneva along the lake. Those rules were often, if not always, adopted after conflicts, and the ones who negotiated those rules were often themselves actors of a conflict. So the ones who created and adopted those rules were the first often victim of those rules. So it's not something disconnected from reality. And that's, I think, very important. Sorry.
If I can ask you to expand the nutshell just a moment.
Sure.
Well, much discussion about the legitimacy, I use the term in quote marks, according to the laws of armed conflict, in striking civilian targets, let's call them energy centers, bridges, since that is what our president has referred to in an Iran context, because they may be dual used by a combatant party. In Gaza, we face the issue of hospitals with Hamas presence, which were struck by the Israelis. Tell me how you sort through this issue of legitimacy of attacks on what are fundamentally civilian or humanitarian infrastructures when they are in some fashion being used by a combatant element.
So, obviously, as you know, I will not comment on political statement because we want to preserve our perception of neutrality. Otherwise, we would not have access to all parties to the conflict. Now, your question is at the heart of one of the challenge we face today, but also tomorrow, especially when you think about, digital infrastructure, when you think about cyber attack, which it's an extension of the battlefield. When you think about this future, sometime present, there'll be this issue around Ws. Okay, our position as ICRC, it's when it's mainly for if infrastructure provide essential services mainly to the civilian population, they should be protected because they have a ripple effect, which is just dramatic. Power supply, it's water, no more water, hospital don't work, and then you go on and on and on and on. So the knock-on effect when you attack essential infrastructure is massive. And in our view, we could also question the military necessity. And obviously, as ICRC, we have a more, I would say, protective reading of what is military necessity and what is proportionate in such a situation. So I would say we are in tensions with many of the biggest army in the world, not to mention them, because they would have a definition of military target which is way more liberal than us. This being said, today there is a consequence to this more liberal interpretation of what is a military target. I will talk about data center. In our interpretation, data center providing AI support to some armies around the world, we would not consider this as a military target because it's also supporting other services than military capacities. However, many armies, especially in the West, according to their doctrine, they would call this a military objective. One of the consequences is that we've seen, especially in this current violence in Iran, that data centers were targeted. I mean, we can extrapolate, what about satellites? What about maintenance services, even in the US territory? What about data center in the US territory? So our definition of military target is it's less liberal, it's more, I would say, limited. States have often a more liberal view of this, but I believe that with this definition, we are exposing a lot of our essential infrastructure, including the digital one, which are often Ws, to great risk. Now, the second point, which is the hospital. Hospital is protected. Obviously, if you use an hospital for a military purpose, it loses its protection. This being said, again, we come back to proportionality. I mean, do you wipe out a whole hospital because a non-state armed group or your enemy is treated in this hospital? No. Can you wipe out an hospital because somebody is sleeping in the hospital? Can you wipe out a hospital because somebody, in the courtyard, shoot at you? Obviously, we come back to the concept of proportionality. And again, we have a more restrictive view. This being said, it's not an easy one, especially for combatant, for officer who have to take this decision. But in our view, the trend is very worrying because the interpretation of this tension goes often in favor of very liberal definition of military targets. And we've seen it all around the world. And I'm not even going to the obvious one that we all know, but you can go to Sudan, you can go to Congo, you can go to Myanmar. I mean, in all those places, you could clearly see that it is a very non-protective view of the law of armed conflict. And the law of armed conflict is not read to protect, is read to allow use of violence, which is, in our view, a perversion of the whole body of law.
Thank you, Fabrizio. Many in the audience are doctors or work in the medical field. How are the rules and laws meant to protect those medical workers and their patients? How does the ICRC support access to healthcare in conflict areas?
So before talking about the technical aspect of how medical personnel is protected and how health infrastructure is protected, I would like to reflect a bit on, the very difficult notion of, for a combatant, for a person victim of violence, to accept one of the basic concepts of humanitarian law, and I think also the oath you took, which is that you were going to provide medical help and assistance to people without taking into consideration whether or not they are your enemy, political affiliation, and you name the list. And in my career, I really reached the conclusion that doing this, being emotionally capable, intellectually capable of separating yourself from the environment in which you work. I mean, a doctor who I'll give you an example. I was in Yemen, in Aden, 3-4 years ago. The Houthi Ansarullah, they launched several ballistic missiles on the airport. And one of our colleagues, several of our colleagues died there. But one of our colleagues, his father was one of the main surgeons on the front line. So he had his son killed by people he was sometimes treating and helping. And I found, he was very clear on his intention, but also very clear on how difficult it was, how emotionally it was really hard to overcome this grief, this anger, and then nevertheless be a surgeon and save the life of people who kill his son. So I would like, when we speak about the law of armed conflict, we go quickly to the technicality of this, but I would like to just stop a second and also stress how it's difficult, how emotionally it's hard in situation of conflict to do the right thing. And I'm not saying this because, to find excuse, not at all. But I think if we don't acknowledge this emotional challenge with the medical staff, with soldiers, with politicians, I think we're not making a service, we're not helping ourselves, because we present something in a very simple and simplistic way. So I really wanted to insist on this emotional dimension. Then, yes, medical personnel, health facilities are protected. If, unfortunately, you are attacked in a situation of conflict, if hospital is attacked, it's a war crime. There is not a lot of discussion around this. Again, as I said, if you have, if you have a military base inside your hospital, obviously it's not protected anymore, but there is an expectation that the use of force is proportionate to your military advantage and the harm you're going to cause to the civilian population. This being said, we see that it's really not enough. So 10 years ago, there was a resolution that we really pushed to make clear how important the protection of medical personnel and hospital is in the world. And it was one of the very, the level of support for this resolution was extremely high. Sometimes you don't see the consequences of this support. Nevertheless, I think it gave us the opportunity also to engage states and work with them on some measures which are really important. The first one is lead by example. Yourself, make sure that your military base are not just next to an hospital, or you don't put your soldiers within an hospital, that you don't target hospitals of military personnel. So the first request was really a lead by example. Then there is an important part on training. In my experience, very often violation of the law of armed conflict, it's more about negligence, stupidity, not knowing the rule, than actually the intention to inflict pain for the sake of inflicting pain. I'm not saying that it doesn't happen, but very often ignorance and stupidity, it should not be underestimated, really not. And that's why training is important. That's why explaining the rule is important. And what I found really interesting in many well-trained army, even if the political level starts having, position on the law of armed conflict which are questionable, often the officers who are well-trained, soldiers, will nevertheless stick to the law of armed conflict because they were trained, because they understood the human value behind those rules, because they also understand that for their work as a soldier, it's also in their advantage to respect the law of armed conflict. So training is important, and I think every day many officers, many soldiers show that beyond the political environment, they know what is the right thing to do. So this is, the measure we recommend. So the lead by example, training, prepare your staff to face situation of violence and conflict. By the way, I suspect that the doctors, we were in the trauma center today where they were treating a lot of weapon wounded here in Houston. They are also exposed to a lot of violence against themselves by the patient or by the people accompanying the patient. So there is something specific to armed conflict, but I believe that it's also applicable in non-armed conflict environment where the medical personnel is exposed to a level of violence which is totally unacceptable. It's great to clap for the nurses and the doctor during COVID, but I think we already forgot about this, and we are unfortunately back to normal where you are exposed, most of you, to a level of violence which is just not, as I said, acceptable.
Fabrizio, following on the conversation you noted, the laws that we're discussing, the rules, were drawn up by the combatant parties after the Second World War, but they were states. We're in a world now, have been for some time, where conflicts often include non-state actors, groups, Hamas, Hezbollah, Houthis in Yemen, other groups around the globe in conflict situations. There is an argument that these laws, these rules are fine in governing relations between states, but they are not able to cope as written with the phenomenon of non-state actors, non-state groups in conflict with organized state forces. How do you address those arguments that they don't work, these rules, or they're outdated?
Look, the rules are very basic. Okay, it's not they are essential, and so you can easily adjust and adapt them to how the battlefield evolves. So, as they are not, I would say, technically very complex, I would argue that they are so essential that it's actually very easy to adjust them and adapt them to the evolution of the battlefield. Even today, for instance, in the ICRC, we work a lot on automated weapon system, on AI, and we constantly make the same conclusion. is that no, actually, there is no such a evolution which would put those rules or would disqualify those rules because not adjusted anymore to the reality of armed conflict today. To the contrary, actually. And this is not just us as ICRC saying it, but it's also states. And that is something very interesting. And I will answer also to your question on non-state armed group. To some extent, humanitarian law, the law of armed conflict, is a bit victim of its own success. In the sense that if you look at how parties, politicians, leader of armed state group was speaking about conflict 20 years ago, they would never, ever refer to the law of armed conflict. They will never frame the conflict in humanitarian terms, because it was seen as not relevant and as at the margin of this issue. What happened is that especially the well-trained army, the sophisticated army, they've never lost a conflict in the battlefield. They've lost it in the public opinion. There are very few really modern army who lost in the battlefield. No. It's just at one stage, their public opinion just does not accept anymore the number of casualties, but also the way their army behave. And violation of the law of armed conflict was actually undermining the case for conflict. And so what we see today is that positive, a lot of states, and I would say even non-state armed group, would frame the conflict within humanitarian terms. However, they also understand fully well that they need to be seen as the good guys, whatever happens, because that's what will allow them to win a conflict. And so we find ourselves in a situation, and I add a third element, which is the information, environment in which we are. I think I could see this in Myanmar when there was a Rakhine crisis, where I was there. Then we could see it in Tigray, then in Ukraine, and for sure around the Gaza conflict, is that because many of us take our information on social media, we will be locked in an echo chamber, where you will have only one version of the story. And you will ignore or not even know about the other side. So, all those three components, the consequence is that the law of armed conflict is often used to justify military objective or political objective. The non-state armed group, such as Hamas and Hezbollah and others, some of them have understood this. And if you go in their echo chamber, they will portray the conflict totally differently than in the other echo chamber. So I still believe that there is room for respect of IHL also in non-state armed group side. I think we have several examples where it happened. However, the echo chamber communication environment in which we operate, the communication being an extension of the battlefield, makes it extremely, extremely difficult to have a dispassionate, non-politicized dialogue on the law of armed conflict. And I believe, Ambassador, that you have a very personal experience of this, because you've been in the middle of those crushing forces and narrative that you need to reconcile to find a political solution to a humanitarian crisis or a conflict.
Absolutely. And I would just make a final comment on your remark, that often it is not deliberate malice on the part of the combatant party that is creating the harm to civilians. It is a question of discipline, of instruction, in environments which are often extraordinarily stressful and challenging for the combatant party.
Yes.
And there I come to a final question for you. In your career, dealing with that particular problem, discipline, education, what do you find to have been the most effective approach?
I think you need a mix, you need several elements. The first one, you need, the respect of the law of armed conflict is a political act before being a legal obligation. So first, there should be a clear political indication, a clear political intention to put the law of armed conflict at the center of your action when you are involved in conflict or when you are preparing for conflict. Then training. We see this, when army, and if I take the example of the US Army, the law of armed conflict is totally integrated into the training of the US Armed Forces. And it is integrated first as, a moral duty. This is the right thing to do because these are our values. There are values in the US legal system, and so this is the starting point. Then there are also very pragmatic reasons, very basic. The law of respecting the law of armed conflict is the most efficient use of your own weapons. Why would you target something which has a low military value and target civilians? It's not efficient for soldiers to use your weapons against civilians. It's not efficient. So you have also this very pragmatic dimension to the law of armed conflict. And then there is this know your environment. Knowing your environment for combatant, it's key. And the law of armed conflict allows you to read your environment. So political will, training, being clear on your intention, and then justice. This is, clear violation of the law of armed conflict, and this is our position as ICRC, should be prosecuted. That's and we're not talking about, the marginal situation, and I think you explained it very well, when you're in the fog of war, when you're in the middle of a battle, it's a tough one. We're not talking about this. We're talking really about war crimes, which is really gross violation of the law of armed conflict, something where, there is no ambiguity. So these are a bit part of the recipe. But the best solution, peace agreement. The best way to respect the law of armed conflict is to find political solution to the conflict we're facing today. That in my career, I started in 1998. In all the countries where I worked over my career, they are still at war today. Because we don't solve conflict. We don't spend the needed political capital to compromise and find a political solution to conflict. And that's the best solution for the respect of the law of armed conflict. Peace.
And on that note, Fabrizio, let me turn to questions from the audience.
Sure.
Okay, I'm going to point at people. Put your hand right over.
Thank you. I wanted to ask, other than education and training, what are the other resources or tools that the ICRC has to advocate or to advance the protection of healthcare facilities or of IHL in general? I think we see so many attacks on healthcare because we do see this impunity gap. Armed actors, belligerents feel that they can sort of act with impunity because they won't be held accountable at the ICC, ICJ, tribunals, et cetera. Maybe there's universal jurisdiction cases, but very few of them, I think, talk about healthcare specifically. So what are the tools in the toolbox that the ICRC has to uphold this?
So the first one, one of the specificity of the organization is that we have a department which is composed of senior military officers. Okay, for instance, in Washington, we have a colonel from the US Air Forces who now is going to Bangkok. We have a captain from the Marine. We have a colonel from the French Air Forces. And because we want soldiers to talk to soldiers. Because, I mean, let's be honest, I mean, most of you are health personnel. If suddenly, as a lawyer, I'm going to tell you what to do in your surgery or whatever, I'm not very credible, but I hope for you. And the same goes for soldiers. You know, it's one thing for me as a lawyer to talk to a captain, a general, and tell him what he should do in conflict. My legitimacy is limited. However, when you have another senior officer talking to another senior officer, going around the technicalities and specificity of a military operation of targeting, we can engage in a way which allows us to have a more constructive dialogue and reach a better place. So this is one of really important tool we have in the way we engage armies and non-state armed group. Then we have our own operation, you know, in the sense that if we have areas where medical personnel is attacked, or if we have mobile clinic who are not safe, or if we have evacuation of wounded which is sometimes under attack. But there we have our own presence in the field. It's about marking also with emblems the medical facilities. It's about notifying the movement of ambulances and evacuation routes to the different parties to the conflict. So we also work and negotiate I would say the safe passage of medical personnel and their facilities. Now, on the ongoing violence against medical personnel and hospital, there is one thing I'm not sure, and I really don't know whether it's worse today or 30 or 40 years ago. I don't know. I'm always a bit skeptical when they say that, oh, it's worse today, because we don't have the data to support this very often, okay? But even if it's not worse, it's just not acceptable what's happening today. Unfortunately, I believe that the national justice is the best option, which means that the state has the awareness, the political will and the strength to prosecute on his own territory the ones attacking medical personnel. By the way, it's even disconnected from conflict. You know, I mean, this is something, it's in some country, it's an emergency to protect medical staff. You know, I mean, I know a bit Colombia, for instance. I can tell you, wow, the condition under which the medical personnel is working in some places in Colombia, it's almost a military base. So the prosecution at the national level, and then there is the international dimension, but there I would say the system is a bit broken, to say the least.
Some of the things you were talking about seem more state-to-state type of rules of war. I would venture to say that the majority of those 100+ conflicts that you've got going in your areas are state internal. And in many cases, those people that are involved in those conflicts, basic education is lacking. How do you can't even identify a command structure, so how do you address the education of the rules of war? I also have another comment. One of our missions when I was in the Army in the medical area was to return the soldier to the battle. Okay? Keeping that in mind, does that affect how the military personnel might be treated? I mean, you're essentially operating as a reinforcement generator for your combat force.
So, for the second part, I think we're really lucky. Sorry, I'm going to put you under the spot. We have one of our ICRC surgeons who's here. And I'm sure she can tell you about in which shape the people we treat are after they go, through surgical intervention in low technology environment in which we operate. So, and I think this is an important thing to keep in mind. Often when we provide, the surgical support, very few, if none, of those people would be in condition to fight again, And unfortunately, also, most of the victims are civilians, And unfortunately, that's something a surgeon once told me. If there is a conflict, become a combatant. It's safer than to be a civilian. Sad reality of current conflict. So on the non-state armed group, look, we have an annual report on the non-state armed group. We have hundreds of them, and we engage them, I think, more than 90%. We have a dialogue with them. We're present in the area where they operate. And yes, they have a low level of education, but I'm sure but it doesn't mean that they can't understand. I think there is education and intellectual capacity, which is, and very often, those groups, it's Darwinism. If they want to survive, only the fittest survive, and often, unfortunately, they know what they're doing. So no, there is a space to engage them. There is a space to talk with them about some of their behavior. But I think what is, often we follow conflict through the news, and so we will see the spectacular things, the massive bombings, but there is an infra level which is not spectacular, but which is probably as important, if not more important. When we can negotiate access to health brigades, when we can secure an hospital, when we can dialogue with rebel groups telling them, look guys, you can't be there. These are not spectacular. You won't have a headline in the New York Times with this, but it has a massive impact on the civilian population. A lot of our work as ICRC and humanitarian worker is not sexy. It's very small things, basic things, but which has an unbelievable impact on the civilian population. So non-state armed group, yes, you can engage. Yes, you can have a dialogue with them. Yes, you can limit sometime the impact of conflict. A lot of, detainees, for instance, between Saudi Arabia, Yemen, the government of Yemen, Houthi, and Sarula. We had to negotiate the release of thousands of combatants. This is the law of armed conflict in action. We had to facilitate the transfer of mortal remains. This is humanitarian law in action. And you can't do that without non-state armed group commitment and involvement. And I'm not judging politically. I'm just separating my political view from this humanitarian success, little success.
I think ladies first. Oh, that's kind. I'm curious what role psychological services play in your treatment of the medical staff as well as the civilians.
Look, I think this is one of my, it's a bit cheesy, but we call it the invisible wound. And it's deeply underestimated in places where there are conflicts and in humanitarian organizations, including the ICRC. We've made huge progress. For medical staff, we have, health staff, who follow our colleagues all around the world. We are way more aware of the trauma our colleagues are going through. Our colleagues who were in Gaza, you're not traumatized. Yeah, okay, you are. Who was in southern Sudan operating in, extremely, extremely difficult circumstances, seeing what they see. There is this awareness today. Where I found it way more difficult is for the civilian population. I'm obviously not a psychiatrist or psychology, but I still believe that there is a story to be told on the impact of violence, trauma on large section of society and how society recover. I've seen this, but in many conflicts. And by the way, it starts with the politician who, how many times I met political leaders, non-state armed group, or even on the state side, have lost their son, have been bombed at one stage in their history, and who are deeply traumatized. But we don't have, I would say, we haven't found a solution to address this. But I believe for me, this is the next border we need to conquer, because I think it's directly related to the capacity to negotiate ceasefire, peace, and stabilize a society. If you ignore this, I'm very skeptical about the capacity of society to recover from violence.
First, let me thank the ambassador and Sonali for putting this really important program together. And I want to thank you for coming out and joining us today. Privately, I'll share with you a story about my mom, who was a combat nurse in World War II in a similar situation to your surgeon. But the question for you today, we know about 1,000 healthcare facilities in Gaza have been attacked. We know nearly 3,000 facilities have been attacked in Ukraine. You mentioned the situation in Tigray in Sudan and South Sudan. There are opportunities to violate the laws of war that give you a military advantage and a battlefield advantage. What we see in many of these circumstances is that there is a part of the world, the Western world, that is really shares your view, which I share completely, the need to follow the rules of law, to be humanitarian. But there's a whole nother part of the world, large countries with huge populations, that seem to shrug it off. How do we change the notion so that the whole world, that Russia, that China, that those countries are also agree to follow the wars, or do we put the rest of the world at a disadvantage? And again, thank you for being here today.
Woo, we would need a special seminar just to answer this. Look, first probably I would express a nuanced view on this. I wouldn't, I'm talking about my personal experience. It's probably too many years that I work in conflict. I have a hard time to give, I would say, I don't know if it's the right word, but a badge of honor to any country around the world. I mean, I've seen too many things. And probably, I mean, that's one thing. The second thing, and here it's not a judgment, it is the reality in which we're living today. Rightly or not, often the West is seen as a double standard. And we can agree, disagree, to some extent doesn't matter. Because that's how a large chunk of the world population sees the West. I also think that unfortunately we have a natural tendency to lecture the world. I will give you a very concrete example. When the Islamic State group lost control of the last territory they were controlling in northeast Syria and Iraq, you had tens of thousands of women and children who had nothing to do except the fact that either they were married to Islamic State group combatant, or they were the son, the daughter of an Islamic State group combatant, or they were just in a territory which was controlled by them. And we put all those people in an infamous camp called Al-Ol, where you had at one stage, 60,000, mainly women and children below 12 years old. And for years, many countries in the West lectured, mainly in Africa, but not just in Africa, many states telling them, you know what, when you're a child, when you're below 18 years old, you're first seen as a victim, and then you're seen as a combatant. And in other words, you need to protect the child soldiers. I'm talking about Sierra Leone, I'm talking about Liberia, and I'm sure many of you have memories of this era. These were not. They were turbulent children, let's put it like this. Now, we need to apply this to ourselves with those kids in northeast Syria. And then suddenly, instead of bringing them back, and I'm talking about 7, 8, 10 years old kids, instead of bringing them back home in many Western countries, suddenly we say, no, these are really dangerous. They are different. I mean, you cannot imagine how much the credibility of our voice is at stake when we don't do what we preach to the others. And that's one of the challenge of the law of armed conflict. The law of armed conflict, you don't apply to your friends. You apply to your enemies. And this is hard. This is complicated. So I would say I would be cautious to put us in a kind of superior moral position. I don't think it's even helpful in our dialogue with other actors, because if that's your starting point, the one in front of you will not listen to you anymore. I would move towards a more sharing of experience, engaging positively. I don't think, in our work, which we do a lot of this, if you lecture, it's over. The discussion is done, it's finished. There is no more room for something else. So I would encourage us to always do better. I would encourage us to reflect on our own practice, and then being in a genuine exchange and humanitarian dialogue with other states, other entity that we perceive sometimes as being our enemy. But this common space of humanity, this humanitarian rule, should be, in my view, isolated from the political, military environment in which it takes place. And by the way, it happens. We organize courses, quite unique, I think, in the world, on really high level military officers. And we have in the room senior US military officer with Chinese, and we just speak about humanitarian action. So I think humanitarian values, humanitarian action, the law of armed conflict, it's a way to build confidence. It's a way of seeing the other not only as an enemy, but also as somebody who one day might be in a position to either protect me or not. That's my 2 cents, I would say, on this complex issue.
I think we can just take one more very quickly, and then we're going to have to move on to the class of my track. Thank you.
Thank you. Well, your conclusion earlier was that we need to have peace, and that would be wonderful. And we're talking a lot about armed conflict and the rules of war. Do you see any place where people are being taught diplomacy? In other words, how to come up with diplomatic solutions, not just not doing bad things, but coming up with diplomatic solutions. Do you see that taking place anywhere, that type of education?
Yeah, I see, OAS today is a perfect example of this, diplomat and embracing complexity. I think what is sometimes frustrating in my world when I'm confronted with politicians or people engaged in, the political dimension of conflict, is that they don't embrace complexity. And what I see, and I might be wrong, is that the people who are capable of embracing this complexity, the ones who are trained, the ones who not are trained but also have lived in those places, are interested, I'm not sure that they always have the way they should have. And that at the end of the day, the proof is that we have no peace. The proof is that if you look back at the last 20, 25 years, 30 years, how many conflict did we end? But almost none. So I would say we need a bit more of Ambassador Satterfield profile and a bit less probably of highly politicized leaders who sometimes have a hard time to embrace complexity. And by the way, I'm not talking about the US, it's a general statement.
Thank you. I think we're going to have to wrap up, but please do find Fabrizio during the break and during lunch.
Thank you.
I have to agree with the statement that we do need more Ambassador Satterfields and more Fabrizio Carbonis in the world. Thank you.
Thank you.
Thank you all.
Great. Ambassador, thank you so much for joining us from London. Okay, we're just going to take 2 minutes to set up for the next panel, and we'll be on our way. Hello, hello. I'm going to call us all back to order. And we're going to go ahead and get started on our next panel. Thank you for being with us. That was a great opening fireside chat between Ambassador Satterfield and Fabrizio. There's so many pearls and nuggets of wisdom there. And I think now that we know what international law says and the different ways of interpretation, we're now going to turn to the challenge of protecting healthcare in conflict. So in humanitarian lore, as I was kind of coming up through graduate school in my career, there was a time when health facilities and health workers were considered neutral and untouchable in war. A medical cross on the facility or a vest was considered sufficient protection in a conflict zone. Well, as we've already heard, that's not the case anymore at all. In 2025, the World Health Organization's surveillance system for attacks on healthcare reported a total of 1,348 attacks in medical facilities, resulting in the deaths of 1,981 people. This marked a significant increase in fatalities among medical personnel and patients in conflict zone, which more than doubled from 944 in 2024. Sudan was the most affected country with 1,620 people killed, followed by Myanmar, the Palestinian territories, Syria, and Ukraine. So let's dive a little bit deeper. First, I'm going to go ahead and introduce our panelists. Let me start with MSF CEO of the US, Tarana Hassan. Tarana is the CEO of Doctors Without Borders in the USA, a role she took on in January 2026. Great to have you. A lawyer, social worker, and nonprofit executive, she brings decades of experience in humanitarian and human rights work. She previously served as executive director for Human Rights Watch, leading over 500 staff across 90 countries. Her career spans work with Amnesty International, UNICEF, Save the Children, and her first mission with MSF was in Somalia in 2007. She holds degrees in social work, law, and a master's in international human rights law from Oxford University. Please welcome Tarana. Thank you, everyone. Next, I'm very pleased to introduce Leonard Rubenstein, the Distinguished Professor of Practice in Epidemiology at Johns Hopkins Bloomberg School of Public Health, and a core faculty member of Johns Hopkins Berman Institute of Bioethics and Center for Humanitarian Health. His prior roles include Senior Fellow at the U.S. Institute of Peace and President of the Physicians for Human Rights. He is the founder of the Safeguarding Health in Conflict Coalition and the author of Perilous Medicine, The Struggle to Protect Healthcare Workers from the Violence of War. He holds degrees from Wesleyan University and Harvard Law School. Please welcome Leonard Rubenstein. And finally, I'm very happy to introduce Trevor Keck. Trevor is the head of policy and humanitarian affairs with the Washington delegation of the ICRC, where he represents ICRC to audiences across the US and Canada and advises staff from field delegates to senior headquarters leadership. Previously, he was an Afghanistan researcher for the Center for Civilians in Conflict based in Kabul, where he documented civilian protection issues and interviewed conflict victims across the country. He holds a master's in law and diplomacy from the Fletcher School at Tufts University and a bachelor's in peace and conflicts studies from Chapman University. Please welcome Trevor. Great. Okay, so the first question goes to all three of you. And we really want to get your expertise in helping all of us understand the nature of the challenge of protection of healthcare worker in conflict. Just talk to us about how this problem affects us here in the United States. Why should this matter to Americans? Who are you seeking to protect? And we're going to first start off with Tarana.
Sure. Well, first of all, thank you, Sonali, for the generous introduction and for assembling us all together. Frankly, there's never been a more apt time for us to be having a discussion like this. I think I want to start with this idea of what is healthcare in conflict before we get into the how do we protect it and what happens when we don't. And we often think about healthcare in conflict as going straight to the pointy end of the stick, where where hospitals are bombed, and that does happen. We'll talk about that in a little while. Where the war wounded, and as Fabrizio was talking about, most of them are civilians, come into a hospital and need treatment. But it's actually a lot more complicated than that, because what happens in conflict is that if you are diabetic or HIV positive and your city's infrastructure shuts down immediately, you don't have you may have to run and leave your medicines behind. And there isn't the sort of health infrastructure available just for your everyday chronic diseases. And I think that's a part of the story, especially in urban conflicts, where we are currently seeing, a vast proliferation of urban conflicts which are affecting densely populated cities. The Middle East comes to mind, but is not just exclusive to that region. And so, when we talk about healthcare and conflict, we are talking about, of course, the injuries that come from war, but we're also talking about, being able to access primary healthcare during those periods. The other thing that we are seeing consistently in conflict these days is that, there are other dangers. And increasingly we are seeing medical workers being specifically targeted during times of armed conflict. It's not that this is a new phenomenon, but we are increasingly seeing a justification of war and justification of tactics, including more brazen rationales for actually attacking specific identified healthcare facilities, including MSF healthcare facilities, and targeting the doctors, the nurses, and the staff who work in those facilities. One of the things that humanitarian organizations do during conflict is that we provide impartial medical care. It is driven by medical ethics, that we do not judge who comes into our facilities. We will treat anyone. And increasingly, we have seen a discourse that is emerging amongst warring parties where there is an assumption that doctors who are willing to treat potential identified combatants, or combatants as they are assumed to be, therefore mean that medical practitioners are tarnished with some sort of, they're basically being put into a category where they are now part of the fight, putting medical practitioners increasingly in harm's way and making them an active target by, I would say, belligerent forces on the battlefield or involved in the armed conflict. And just to go back to, those are quite often, and the majority of the times, those are state actors. Those are armies who are making those. Those are the people who have had the training, who know international humanitarian law, should certainly know better and know that they're committing war crimes. The other thing that happens in terms of conflict and armed conflict and healthcare is obviously the ruptures that occur. When you have conflicts like we are seeing now, where bridges are being targeted, where infrastructure is being targeted, that creates ruptures to things like supply. So for humanitarian organizations, for emergency health providers, trying to not only get supplies into your facilities becomes increasingly challenging, but then we also see a rising number of attacks on actual transport, medical transport. So unfortunately, we have seen ambulances being targeted and other facilities being targeted. But I can tell you that increasingly what we as MSF are seeing is that, the providers of care are just one part of the problem. When healthcare is attacked in armed conflict, the people who really suffer are our patients and our communities. The bridges that we rely on to get supplies into our hospital are also the bridges that patients need to cross to access those hospitals. And we know for a fact that our patients risk from everywhere from Sudan and South Sudan to Gaza. We're seeing our patients increasingly face checkpoints, belligerent actors, parties to the conflict, as well as the risk of indiscriminate shelling, kidnapping and killing, just to access healthcare they deserve.
Thank you. Lynn, can you share your thoughts?
Sure, and thank you, the Baker Institute and to ICRC for inviting me to speak to you. I'm always very happy to spread the gospel, such as it is. I want to start by saying I've been working on this problem for 30 years. And there has never been a time in those 3 decades when I believe we have been in a greater crisis of protection of healthcare than there is now. Fabrizio mentioned we don't have a lot of longitudinal data, but we have pretty good data over the last 5 years. And a British medical journal article published within the last 6 months or so, based on data of the Safeguarding Health and Conflict Coalition, found that the number of attacks on healthcare almost tripled between 2020 and 2024. That's staggering. Also, I will take a little different perspective from Fabrizio. I don't believe, and I think the evidence shows very dramatically, that these attacks are not because of negligence or ignorance or lack of training. It's because it's contempt for the law. And we see this in Gaza, we see this in Sudan, we see this in Myanmar, we see this in DRC, we see this everywhere. So it's also a crisis of values. And what we've also seen is that the values of the people committing the offenses are not in harmony with the values of the global community writ large, that's us. And we can see this in various ways. I'm not like the ICRC, I can name names. I don't have to be diplomatic. So in 2 attacks, one threatened and 1 attack in Iran. You may remember at the beginning of the war, a girls' school was hit by either the United States or Israel. Hundreds of girls were killed. And why did it make the front page for days on end? Why were investigations demanded? Because the public was appalled by this, that they believe in humanity in war. They believe you shouldn't kill schoolgirls in a war. And similarly, in the last couple of weeks, why is it that Trump's claim they're going to destroy Iran by committing massive war crimes is getting so much pushback? Because the American public believes in the values that go back to the founding of the Geneva Conventions and the ICRC in the 1860s. And in fact, healthcare was the first subject of the Geneva Conventions, the only subject in 1864, and we have those values. So how does this manifest itself in daily life in a war zone? Tarana talked about the picture of how it undermines population health in so many ways. But over my career, I've talked to many, many health workers, and 90% of them, or 95% of them, are not humanitarians, they're local health workers. And I just want to share a couple of stories. One is a doctor in Sudan who couldn't go to his hospital because he'd get killed on the way to the hospital. So he opened a clinic in his home for people, and he got drugs. Somehow, he got it. Very entrepreneurial guy, got holds of medications to treat people. And the RSF forces, the rebel forces in Sudan, came to him and said, "You can't treat these people. These people are our enemy. You can only treat our forces. And we're going to kill you if you do." That's what he experienced. And of course, he was completely traumatized by that. He also felt what we call moral injury because he couldn't do what he was trained to do when his ethics told him to do, was to treat every patient impartially. Let's turn to the war in Syria, which is happily over. Here's a story a doctor told me. Their hospital was shelled, and it kept functioning remarkably with generators, but they didn't have much fuel for the generator. And so they had to make these terrible decisions, not the usual triage decision about who gets treated first, but they didn't have enough fuel to treat everybody. And this father, son, like a 5-year-old or a little child, was not going to be able to get treatment because they didn't have enough fuel to treat him. And he cried, the father cried, and he, 20 years later or 15 years later, is still traumatized by this. Then Ukraine. I was in Kyiv and visited the main hospital, maternity hospital in Kyiv. And they do a remarkable job. Every time there's an air raid, which is like almost daily, they move all the women in the hospital about to or having given birth to the basement, which is a basement. It's not exactly a nice place. They've furnished it and they've got a delivery room. It's all done. But they do this like in the middle of the night, have to move everybody down, and it's become routine. But imagine what it's like for the women who aren't used to this. The staff have kind of figured out how to deal with this, or they think they have, although they're also traumatized. And they have to move these women in the middle. They're in labor. They got to move them down 3 flights and try to get safe childbirth, many of whom haven't been able to access good prenatal care because it was too dangerous. And these are just 3 little stories. These are repeated so many times all over the world. I could tell many stories about Gaza too, including a young boy, a 16-year-old, was killed inside a hospital. In a hospital, he was killed because the Israelis shelled the hospital after one single person who they claimed was a Hamas commander, but in fact had been wounded and was in for medical care, which of course is protected in the Geneva Conventions. So we have this staggering problem, and it's a problem of violence, it's a problem of values, and we'll talk later about what we might do about this. But this is why if the question is why should we care? As health professionals among you, there are colleagues. There's nothing more important than solidarity. We have solidarity. We had solidarity during COVID with people who were struggling to provide care when they didn't have what they needed. And as human beings, as members of communities that believe in values, the values that have surfaced when we've heard about what's happening in Iran and attacks on hospitals, civilian schools, that we as a nation and nations of the world have to care about what's happening. Thank you.
Thank you. Trevor, over to you.
Thank you so much, Sonali, and it's really great to be up here with such a distinguished group of panelists, and thank you all for coming and paying attention to this important issue. I think that Tirana and Len have really covered some of the issues, so I'm not going to repeat some of the issues I was going to note. What I think I'm going to do is kind of recap some of the general themes, I think, that also Fabrizio touched upon. So attacks on healthcare are global, and as Len highlighted, increasing over the last several years, happens in conflict zones, also, as Fabrizio mentioned, happens here in the United States, in Houston, I'm sure. A lot of the work we do it's not only in conflict zones, and so our health staff also experience some of these challenges in places that are violent but may not rise to the level of conflict. So I think that's an important point just to reinforce. And then it has different causes. Yes, there are definitely, attacks on healthcare can be part of a deliberate strategy, a scorched earth campaign to target hospitals and health providers. Absolutely, that happens. And there's many cases like that. But there is the result of ignorance or negligence or operational failures. At least that was one of the major issues that led to the really unfortunate attack on the Kundus hospital over 10 years ago, which Tirana may speak in more depth about. So we know that was a big problem of operational coordination, operational failure on part of the US military, which they've been public about. Soldiers not getting trained properly, We also know what happens quite often in many different places is that sometimes you have fighters that will use the hospital or use an ambulance in ways that violates the law. That's not allowed. Attacking parties have an obligation both to not attack a hospital, but also other opposing fighters can't be using ambulances or hospitals to shield themselves. But both of those things do happen, and often, sometimes, the fact that a non-standard group, or sometimes even a state, is inside of a hospital might provoke another to then attack the hospital, or it creates a perception that hospitals are now fair game, as Tirana was speaking to in earlier. We also know there's also times when medical staff deny care because of fears of being prosecuted by the government, or because they just don't believe that everyone is deserving of medical care. That's also a big problem we see. And it goes against medical ethics, of course, and it's unlawful. So it's really important to know there's a lot of different causes, because each of those causes require different responses. Then I think Tirana hit on it really well that, yes, there's and I think Fabrizio spoke to this earlier as well, there's the immediate effects of attacks on hospitals or health clinics, loss of life, or it takes that hospital or health clinic out of commission or reduces its capacity. But then you have the cascading effects, which we've seen in places like in Gaza or in Yemen or other places where you have these urban conflicts, and you're just as likely to die from being wounded, a war-related injury, as from cholera or an easily treatable disease that we can treat very well here in the United States or in functioning health systems. But when you have sanitation, water, electricity, and healthcare all breaking down at the same time, now you've just spiked the chances of people dying from those easily treatable diseases. So one of the things we try to do is also work to ensure protection of all of those facilities I just mentioned. There was an interesting case last year where our team in Eastern Congo worked with local authorities to try to prevent attacks on an Ebola lab. And that's an interesting example because it speaks also to what Len was speaking to. Yes, why should we care? We should care because we should all care about what happens to people everywhere, and there should be solidarity. But attacks on healthcare in places overseas can also create risks to people here, right? Ebola pathogens could have gotten out, someone could have gotten on the plane and flown right here to the United States. And we know there was an Ebola outbreak that was contained a decade or so ago. So these things, I think that's the issue, maybe a little bit different with global health, is that there are outbreaks, obviously, that can happen that spread around the world, and attacks on healthcare make that more likely. So I'll leave it there, and we move to the next one, yeah.
Great, no, thank you so much. Really excellent points across the board. And I think just following on to this discussion, all three of your organizations have been involved in monitoring attacks on healthcare workers and putting out reports noting a rise on the attacks on healthcare in conflict zones over the last few years. This despite, years of advocacy, years of trainings, a lot of effort has been put into all of these issues. A landmark Security Council resolution in 2016. And we've talked about this already, but I'd love to just hear a little bit from you on why these attacks are increasing and how are your organizations working to address the problem. And, one thing that really just many things struck out when we had the conversation between Ambassador Satterfield and Fabrizio. But one issue that I think is so difficult to deal with is the issue of interpretation and how different militaries and different armed actors and humanitarian organizations and ICRC will interpret the space on the law of armed conflict and what is a permissible military target and what is proportionality or not. And, I'd love to hear if you have any thoughts on this issue of interpretation. I mean, who ultimately adjudicates? So let's go ahead and first start with Len on this one.
First, I think, thank you, Sonali. First, I think we have to recognize, I think Fabrizio alluded to this, about why are these attacks happening? And I think he mentioned, and is absolutely right, there are military reasons for attacking hospitals. But some of those military, which are not legitimate, I mean, it's in a hospital's in a strategic location, or it's convenient because as a tactical matter, but the reasons have gone way beyond that. And those are, they're not justifiable, but some of the reasons are much more pervasive, deep, and disturbing. For example, in many wars now, populations are dehumanized. The entire population is the enemy. And we see this all over the world, where you're dehumanizing the people. There's often some kind of genocidal aspect to this. So depriving people of healthcare is a pretty logical thing to do, or a natural thing to do if the population itself has become the enemy, and we see that everywhere. Secondly, and this goes to the law, I have a different view of the law here. I think the ICRC, we'll talk about this later, has a wonderful project to restore global commitments to international humanitarian law. And we've gotten into a situation where there are claims that the law allows a lot more harm to civilians and to patients and doctors and hospitals and all other health workers than it actually does. And there has been a result, a kind of political paralysis. I wrote a book on this subject, on attacks on healthcare. It was published 5 years ago. And I gave maybe 3 sentences to the idea that it was legitimate to attack a hospital because it's creating, it's engaging in acts harmful to the enemy. That's the legal standard. It wasn't a huge issue then. Now it's a huge issue, and as I said, naming names, every time Israel attacks a hospital, it says Hamas. It doesn't say what Hamas did, it says Hamas. It's attacked hundreds of health facilities in Lebanon in the last couple of months. Hezbollah. The standards are very strict. A hospital may lose protection. I'm not going to give you a legal lecture, but we need to understand that the narrative of legitimacy of attacking hospitals has gotten into the water, and everybody's drinking it, and it's wrong. There are so many protections before you can attack a hospital, or the way you attack it, even when you believe it is being used to create some hospital, some acts that are harmful. So Fabrizio mentioned one, which is proportionality. You can't destroy a hospital because a couple of combatants are inside. You have to give us very specific warning to cease the misuse of the hospital and not attack it until it's been ignored. That requirement of the law is almost universally ignored. You have to take precautions to protect patients and the medical staff if you attack a hospital, because they don't lose the protection because it's a combatant doing something bad in that hospital. You have to make sure that intensive care is preserved, that electricity is preserved so people don't die when because they don't have life support. You have to preserve its functioning as much as you can. That's ignored, and instead we have this narrative. So we have a huge issue, and it's our responsibility to use our values and the values that are embedded in the law to say this narrative is false, it's eroding the law, it's creating enormous damage, and there needs to be accountability for this. It has to be called out by name, it has to be called out by action, and I'll talk I guess at the next panel about what we all can do, what governments can do, but we have to make sure that we don't accept the erosion, the undermining of both basic values of humanity and how populations are treated, and how the law is not undermined anymore in a way that is paralyzing action.
Thank you. Tarana, I'm going to move back to a history that was very painful for MSF, but on a personal note, it was painful for me because I was in the White House at the time as the Director for Global Health when the US military attacked the hospital of Kundus in Afghanistan. Those of us who were inside the machinery were horrified that such an incident could occur. And, a small anecdote was, I think myself and a few others, we were probably locked up in a secure room and saw dozens of missed calls from our MSF colleagues trying to get a hold of us, and just this sinking, terrible feeling that this was not normal and something must have happened. So let's talk about that if we can. The hospital, the MSF-run hospital, suffered a horrendous attack. I think 42 people were killed, including MSF staff, patient, and caretakers. The U.S. military acknowledged it was a mistake. I was listening in on the call when President Obama called MSF Executive Director Joanne Liu. It was a really rough call to listen to. And I'd love it if you could just share a little bit about any lessons learned from that incident. I'm aware that MSF did engage with the U.S. military after that, and there were certainly recommendations to changes in practice that came out of that. So could you talk to us a little bit about that?
Sure. I think the Kundus Hospital, just for those that might not be familiar with it, is a very dark moment in MSF's history. The Kundus Trauma Hospital is in northern Afghanistan. It was described by my MSF colleagues as being a bit of a jewel in MSF's crown. It was just over 10 years ago, actually. I think it was the 3rd of October 2015 when the attack took place. In the weeks leading up to the attack on Kunduz, there had been increased fighting in and around the area, and the teams had been treating civilians who had been injured in a stream of patients had been coming in. It was quite chaotic. They had actually had to postpone a number of surgeries so that they could deal with the war wounded who were coming in. There was a reprieve on the 3rd of October. The teams actually started working through the night to deal with the backlog of patients that we had. And at approximately between 2 and 2:08 a.m., loud explosions were heard, and basically the center of the hospital was hit, and this is where the ICU was, this is where the 2 operating theaters were. The attack was from the air. It was a US aircraft, and there was sustained and targeted fire at the hospital for an hour. And Sonali, you alluded to this. We do have protocols that were triggered. The protocols that exist to be able to protect healthcare facilities like the Kunduz Hospital were in place. What they are is a humanitarian notification system, for example. So we have staff dedicated at MSF that will give coordinates of our hospitals and of our clinics to the relevant military authorities here in the US. That goes to the Department of Defense here. Also, there are points of contact wherever we are able to make them, and that is in most places, with the command structures on the ground. They are provided not only with what we do in those facilities, but they are actually given the GPS coordinates. Hospitals are properly signed both from the air as well on the ground. In all of our facilities, if you ever have seen a photograph of an MSF facility or you have been in one yourself, you will see a sign with no weapons and a big red cross through it. We don't allow weapons into our facilities to ensure that we maintain that medical neutrality. All of that was in place in Kundus. The attack went on for a full hour, for an hour. The calls went in within minutes, within the first 20 minutes, I believe it was, of the attack. There were a number of, number of things that happened during this attack. We lost, as Sonali was mentioning, 42 of our colleagues. 42 people, 24 were our colleagues, 14 were our staff, and 4 were caregivers. People were also killed as they were actually fleeing the facility. They were actually mowed down from the sky. What did we learn from that incident is that, all of those protections continue to need to be there. We have, wherever we believe that it is appropriate and it is safe to share our GPS coordinates, to even talk about when we are having movements, so that the movements and transport of our staff, personnel and patients can be protected. We will do that when it is deemed appropriate too. The challenge that we have when it comes to Kundus is 2 things. We're really talking about what sort of accountability is there to be when something like this happens, and how do you establish the facts about what happens so it doesn't happen again. For us, we have taken, as MSF, we did an internal review and investigation. We called for an independent investigation. Actually, there is a mechanism that is enshrined in the first optional protocol for a independent humanitarian fact-finding commission. That is, I don't know if it's true, but at the time of the request after Kundus, that had never been activated. I don't know if that has changed since. But that didn't happen. We asked for it immediately after the attack. We also requested, but we felt it was important to have an independent investigation. The US did do an investigation. Their results, so did actually the Afghan authorities. There were 2 reports. We got a heavily redacted version of that. And it declared that there was not a war crime that was committed because there was no intention for the attack. We remain unsatisfied with that response because we do have questions of whether the warring parties were the appropriate people to do such a fact-finding mission. And also that, to establish the facts to ensure for the warring, for what happened in Kundus and in the future, an independent establishment of the facts is really what's necessary. But what we're really getting at here, and I think when you take what has happened in Kundus and the fact that the sort of attacks that have continued on healthcare, on facilities, including ours, in South Sudan, in Gaza, in Yemen, in Sudan, these are happening now. They have been happening since the 10 plus years since the Kundus attack. Why are they happening? It's because there is impunity. There is, and we have heard this before, there is a fundamental disregard of the principles that we as independent, as health workers, we as independent organizations and health workers rely on to be protected during times of armed conflict. There is a growing pattern that we are seeing emerging by states who are the duty bearers. It is we are doing what we can by using the reporting mechanisms to make the information known, to make sure that we keep the humanitarian nature of our facilities. We are doing that. But at the end of the day, compliance with international humanitarian law, compliance with the Security Council resolution that was passed after Kundus, which reinforces and states agreed to protect medical workers in conflict, that is up to the states. And the pattern we are seeing is that states increasingly, particularly those involved in conflicts, but also those that are supporting their allies who are active in conflict, are cherry picking. International humanitarian law isn't something, it's not a buffet, right? You don't just walk around saying, you know what, today I feel like a little bit of a protect a hospital, but those schools, let it be. That is not how this works. You sign up, you are locked in. If you diverge from these rules, there have to be consequences. Where it is going wrong is that, and we're not just, states have the responsibility, but once you are in the theater of war, once you are a party to an armed conflict, so going to the question that I think that you posed to Fabrizio about non-state actors also are responsible for not attacking hospitals, healthcare workers, and facilities. They are to be held to the same standards. Once you are on the battlefield, that is your obligation. So I will end by saying that this is not doom and gloom. That this divergence from the principles and the lack of compliance we are seeing is a choice. There has to be an increased cost for breaking the rules. And if we do not see that increased cost, because it does have a deterrent effect, and that deterrent effect ultimately means it will save the lives of medical workers who are working in armed conflict, and it will save the lives of tens or hundreds of thousands of patients who need to access those facilities.
Thank you. Trevor, let's turn to you. ICRC has launched a whole initiative on this topic, completed over 24 reports and studies. Can you talk about ICRC's initiative and what your recommendations are, and how do you bring this into ICRC's engagement with both state and non-state actors?
Yeah, thanks. First, I want to quickly come back on the question that Len answered, just very quickly, because I think it's really important. Why is this increasing? The broad interpretations of the law is a real problem. That's something we've identified, and because obviously the way you interpret the law matters, just as it matters here domestically. If you interpret it in a way that gives you way more permissions and latitude and reduces protections for civilians, then of course that's going to result in more harm to civilians. So I think that's really important, that there's a number of states out there that do interpret it in ways that may not align with what we would see as a good faith interpretation. And then there's also just been this rise in conflict, which I think Ambassador Satterfield was highlighting, more actors on the battlefield. So I just think it's important to highlight that, as well as the asymmetric conflicts. So the conflicts, a lot of these conflicts, someone in the audience rightly highlighted, a lot of conflicts between states and non-state actors, and oftentimes in those conflicts, both actors are somehow abusing the law. Sometimes the non-state actor might fight from or take advantage of a hospital or medical facility, and then a state might also see advantage in attacking these facilities. So that's why I just wanted to highlight some of those summary reasons. So what are we doing about it? Well, as I think Tirana also mentioned, this issue has not, yes, there's been a rise in recent years, but this issue has been happening for a long time, attacking hospitals, attacking medical providers. So we started this campaign in 2011 called Healthcare in Danger, and what it sought to do is, number one, raise awareness of the problem globally, and then try to find ways to engage states, non-state groups, other stakeholders, including medical providers or NGOs operating in this space. And we ended up producing about 15 different reports for these different stakeholders, including militaries as well, 2 different reports for militaries, with very specific kind of practical recommendations for everyone, for health providers and NGOs on how to protect themselves. Shouldn't have to take these kinds of what we call passive security measures, so how to harden your structure essentially, to make sure that you reduce the chance of attack by hospitals. One very easy example is these no weapon signs, also flagging hospitals, things like that. So a lot of very practical steps to protect hospitals or health clinics. And then for militaries, steps for them as well, things like incorporating these, looking at this issue as you develop military guidance or doctrine or rules of engagement, and making sure you're thinking about in planning as well, planning and exercises, thinking about how you protect or limit harm to healthcare. Also recognizing that it's not just about not attacking hospitals, but it's about making sure that you protect the whole, if you're in an urban fight, if you protect the whole systems that support the health systems. So that's a bit of on our Healthcare in Danger initiative. And then what we've been doing recently, is Len talked about this as well. We've been, last couple of years, we started this initiative on trying to reinforce the protective scope of international humanitarian law. So getting to the point of people are not, some states not interpreting it in ways that are in good faith, or that are lacking practical steps on how to implement or comply with the law. We're trying to address both in this new kind of global work stream, of which one of these tracks is about how to work on protecting hospitals and healthcare specifically. We've also, I think everyone on this stage was involved in, not everyone personally, but our organizations were involved in trying to shape this resolution. The Security Council 10 years ago, and so there's going to be an effort to follow up on that. What it did is call attention to this problem and urge states all to take quite specific practical steps to protect healthcare in conflict. Why don't I leave it there, some of what we've been doing, so we have more time.
Great. I have a few more questions, but I think we're going to just take a pause and hear from the audience. And I might actually also ask, what is, I forgot my phone, so how much time do we have for this session? 11:08. Okay, yeah, let's turn to questions from the audience.
Hello, my name is Bobby Wilkerson. I'm a delegate here at the Baker Institute. My question is that on a global scale, I'm trying to think large here. I'm talking about the diaspora. How much is research? Would that be a viable solution to some of this treating patients directly? Could we look at hospitals in those areas and come up with ways to incorporate research to better administer and better be responsible for the whole of the community, of those communities?
Someone want to take that?
I think what I would say is, I think engaging with diasporas in general is really important. Also to like pass messages to, because they're often really important in how conflicts are waged in their home country. And so we do some of that engagement as well, to shape messaging, take their perspectives. I'm trying to now tie it to research. Could you maybe elaborate on that a little bit more so we kind of understand?
In Southeast Nigeria, in 1960, they gained their independence, Nigeria did, and as a result of that, they still were left with the Europeans that ruled them at that time. And a lot of the men in the community, they were not able to take care of their families, and it caused a chaotic situation. And they came up with the idea to build a mental health hospital in southeast Nigeria. And it's a 501c3, to be frank with you. And it was going to just they were talking about the equipment used was substandard and all that they had available. But the main point about it is that were they really protecting the diaspora just by treating directly, looking at treating lambs, save instead of cutting a lamb, treat a lamb and put them in rehabilitation. Those kind of immediate solutions. There's no hospitals within about 30 or 60 miles of the villages in those areas. And so my question is that in those areas, those are certain diseases, children, the life expectancy of the child in southeast Nigeria is actually about 15 years, about 15 years. So I'm looking at now maybe treating diseases, bringing in research scientists, labs, putting in labs to treat those, to look at those areas, those diseases, and maybe come up with possible, not use them as guinea pigs, but just to come up and try to be responsible in that area.
So our next panel is going to be several of our esteemed physicians who have served in the field. So why don't we save that question for them to answer when we get to the next panel, because I think that's an excellent question. But we're going to kick it to the doctors and the medical schools who are here. Okay, we are. I think we made up a little bit of time. Does anyone else have any questions? Okay, let's take a few more, and then we'll just take a quick coffee break, and then we'll return.
Thank you so much. So earlier we talked about that with all the conflicts going on globally, many of these are internal, and so I do some work with an organization in Haiti, and so I know some of our panelists have done some work in Haiti. In particular, I wanted to hear some thoughts around that. And more specifically, with MSF in terms of some of the hospitals that have been shut down there and things like that. In our case, we have been given permission to expand our clinic to a hospital, and which is great, but at the same time, it may open up some other targets perhaps, maybe. I don't know, because we've been, in a blessing, sensible way, we have not been hit from gangs, etc. And so as we embark upon this plan to strategically, prayerfully, and hopefully go to a hospital, what are some thoughts from the group here in terms of success to really do that as more and more people are being displaced and coming to our community for healthcare, and as we continue to embark upon this journey, some thoughts in terms of being successful as we embark upon this journey.
Tirana, do you want to take this one?
Sure. I just came back from Haiti, actually, and it is an incredibly challenging context, and international law that applies aside. Healthcare has been targeted in Haiti, and so I think the first thing I would say in response to your question is that's fantastic. What I heard from my colleagues in the Tabar, my Haitian colleagues in the Tabar hospital, is go back to the US and tell people we need more facilities. We can't keep doing this on our own. We have nowhere to be able to refer. So if you have that ability to set up, the need is there. There is a willingness from the community. One of the challenges, I think, from an operational perspective in a context like Haiti is the, again, it's this protection of healthcare and the neutrality of services. Not being targeted by gangs is one thing, but increasingly in Haiti, we are seeing the security response to the gangs is being one of the things that has seen an increase in attacks in heavily populated areas. So the Haitian government is currently using a security company, private security company, to back up the police for its security efforts to curb the gangs. What we are now seeing is they're using drones. So the drones, these are small quadcopter drones that have explosives that are strapped to them, and they just barrel in and to their target. Now, when you are doing that in densely populated areas where there are a lot of displaced people, we're seeing a lot of injuries. People can't then access health facilities. So the more proximate that you can get, depending on the sort of facility that you're going to offer, but people can't move easily to health facilities. So the more proximate you are to the population, the better. In terms of the safety of actually being able to operate, we have had our challenges. We actually suspended operations in Haiti a few years ago because an ambulance was, and one of our ambulances was stopped by sort of the community protection services. Our patients were taken out of the hospital, 2 of them were executed. And it was because they were perceived as supporting the gangs. And because MSF works in gang-controlled areas, our facility, our impartiality was not being respected. So I think the investment in the community, both on the government side and in government-controlled areas, in the gang-controlled areas, as they're crudely described, that doesn't do justice to the complexity of what's happening in the country, is really important to ensure that there is that level of safety and adherence, and you have those deep relationships with everybody to notify them about what you're doing and to ensure as much as you can that your facilities are respected. We are in constant contact with everybody to be able to ensure that we can move and continue to run our facilities.
Great, thanks. So I think we're going to break right now so that everyone can take a coffee break, but please feel free to approach all of our speakers and ask them further questions. We have sign-up sheets. Where are the outside. If you'd like to do the virtual reality experience, and also, drop your business cards into the folder? Drop your business cards into the folder so that you can get onto ICRC's mailing lists. Is there anything else, Tom? Oh, business card in the mug, sorry. No, not a folder, a mug. Let's resume at 11:30. Okay, great, thanks everyone. Okay, everyone, is this thing on? I think so. All right, if I can call you all back to your chairs. We're going to go ahead and start it with our next panel. And then after that, we will break for virtual reality and for lunch. So, okay, well, welcome back, everyone. Thank you again for being with us this morning. And welcome to our next panel, which is about exploring solutions. And we have here an amazing panel of frontline doctors who have been working in crisis and conflict settings as physicians and can speak to the real world experience. So I'm going to first introduce our panelists. Okay, let's start with Dr. Heather Hawk. Dr. Hawk is the Associate Professor of Pediatrics of Baylor College of Medicine and Medical Director for Children's Health at Texas Children's Global Health Network. She is also the the current chair of the American Academy of Pediatrics section on global health. Welcome, Dr. Hawk. Next, we have Dr. Ann Morrison. Dr. Morrison is a surgeon at ICRC and an adjunct instructor in surgery at the Center for Global Surgery at the Baylor College of Medicine. Welcome. And last but not least, happy to introduce Dr. Rachel Davis, who is also co-host of this event and helped put this all together. Dr. Davis is the Associate Professor for Surgery, Division of Trauma, Bariatric, and Acute Care of Surgery, Baylor College of Medicine, co-director of Baylor Global Programs, and the director for the Center of Global Surgery. Welcome to you all. Okay, well, why don't we go ahead and get started while I am fumbling with my papers. One moment. Thank you. Okay. So we want to go ahead and really just start with the clinical reality on the ground and really ground the conversation in lived experience before we turn back to policy. And I'd love for each of you to describe what it actually looks like when healthcare protections break down. From your perspectives, what does your training or field experience tell us that the policy cannot? And we're going to first start with Dr. Hawk.
Yeah, thank you. Well, I'm happy to be here today as a pediatrician voice. And so I really want to focus my remarks on children. And today, 1 in 5 children live in an area affected by armed conflict. So really, armed conflict is central to the issue of pediatrics. It's not something that's marginal. It's really one of the defining issues of child health of our time. And so, while I have not personally been on the front lines in humanitarian settings, I support a broad portfolio of global health work. And as my pediatric training tells me that there's a few things about children that we really need to keep in mind. So children are not just younger civilians. They're biologically different, developmentally different, and socially different and more vulnerable than adults. And so this means that children suffer disproportionate harms and oftentimes invisible harms when healthcare protections break down. And so kind of delving into this a little bit more deeply, from a developmental perspective, children's brains are still developing, they're growing, and so when conflict disrupts things like vaccines and mental health support, neonatal care, routine monitoring of child growth and development, this can cause disruption during these critical windows of development that reshapes the child's entire life trajectory. Secondly, for children, they're physiologically different. So they have different exposure risks, different toxicological susceptibilities, and conditions that might be survivable for adults may not be for children. And so thinking through the unique physiology of children is also important. And then third is socially and structurally. So children are entirely dependent on adults and systems for protection. And so when their caregivers are killed, displaced, or overwhelmed, children lose access to care and education and legal protection. And so from a pediatrician's standpoint, when healthcare protections break down, what we see is a compounded loss at critical windows of development, and often with consequences that can last throughout the entire life course. So children are really carrying forward everything that they experience during conflict biologically and developmentally through their life course. So I think from my perspective, just really want to emphasize that when healthcare and conflict settings breaks down, children have unique vulnerabilities. And so, protections must specifically address children.
Thank you. Dr. Morrison.
I was really glad to hear this question because as a surgeon on the front lines, this is what I see and this is what I do. And a lot of the people who write the policy, who advise the policy, who are involved in the policy, regardless of their intentions or what side they're on, they don't see the results of their policy on the front lines. They see a report of 65 killed, 130 injured. They don't see what those dead bodies look like and what those injured people look like and what their families sound like when they're grieving and crying. And when you have to be the one as a surgeon who says, I went in there, I did everything I possibly could, but there was nothing I could do. Their injuries exceeded what I could do. Or I saved their life, and it's something you're proud of when you finally save a life of someone who's dying, and you say, oh, but their genitals and their legs were blown off. It's not so much a success anymore. How is this person going to come be a farmer again? How is this person going to return to their family and provide for their family again? What are the real results of the policies that are in place and the violence that follows? And so that is what I would say that my lived experience is. It is seeing people, like human bodies, people with families and lives and thoughts. And it doesn't matter if you disagree on any sort of issue, if you look different, whatever, like at the end of the day, we're all people. And when you're on my operating table, you're naked, you're floppy, you're vulnerable, and you're suffering. And it doesn't matter who you are. If you're a gang member or a mobster or a fighter or whatever bad things you've done in your life that makes you the enemy of somebody else, by the time you get to me, you're just a human who's suffering. And one of the things I really love about the Red Cross and their approach to conflict is they're seeing the humanity of everyone. Obviously, in any conflict, there's the bad guys who are obviously bad, and then the good guys who are fighting back. But at the end of the day, there is no bad and no good. We're all humans, and I think the neutrality and impartiality, while frustrating to some people who see it as colluding or whatever with undesirable parties, is necessary to get access to everyone, because the truth is that everyone deserves humanitarian aid. Everyone deserves access to health care, regardless of what came on before then. So that would be my response.
Great. Thanks. Dr. Davis.
Yeah, thank you for having this panel. So I think I'll speak a little bit from an educational perspective. So as she mentioned, I'm Rachel Davis. I'm a general surgeon. I work across the street at Ben Taub. But I direct the Center for Global Surgery, where we have a bunch of educational programs for low resource settings. And I think we can all see that there's a very clear link between places that are vulnerable and places that are in conflict. So there's an enormous overlap between resource limitations and places that become engaged in conflict. And so in 2021, there was a group in Myanmar that contacted us to ask for trauma education because there was a military overthrow of the government, and many of the trauma faculty in some of the universities were actually removed from those places because they were seen as colluding with the prior government. And so you suddenly had this disconnect where there are students with no teachers, and there's an increased volume of trauma that's being experienced. And so those students didn't have anyone to turn to while they're trying to sort out how to manage these patients, and then many of the faculty were displaced. They're trying to care for people who've been victims of violence in rural areas, and now they're seen as enemies of the state. If they're caught carrying medical supplies, they're at risk for being jailed. And so they had contacted us for educational support, and I thought surely at that time there had to be other resources. So I spent a lot of time actually trying to redirect them to some freely available educational resources, but unfortunately there weren't actually any specific to conflict. And so we ended up creating something called the Global Trauma Collaboration, where we have met. We try to do it about every 2 weeks, and we've been doing it since about 2022. And again, from the educational perspective, I sort of thought that what would be meaningful about this would be the education, teaching about how to do a thoracotomy or a laparotomy from the medical perspective. But in the end, I think that really what is the most valuable about it is that We meet with about 70 surgeons and clinicians who are trying to manage trauma care in combat zones in Myanmar, but also in Haiti and in Gaza and many places around the world that are in conflict. And it's de-identified for their safety, but it gives them a time to come together and realize that they can share these experiences with someone else. And it doesn't matter what conflict or where this conflict is, but they know that somebody else is having similar experiences. And so they might ask technical questions like, what suture do I use, or how do I approach this case? But it also might be non-technical questions that we address, like, if I'm operating and someone is shooting at me, am I allowed to shoot back at them? Or if I have a patient and the patient is critically ill and I don't have the skills to manage this, but I know that I can't transfer that patient because at a checkpoint they will be killed and my staff will be killed. What do I do? How do I manage the situation? And we walk through with them difficult scenarios. Like maybe a year or two ago, there was a situation where in one of these regions, there was an opening of a government building. They were handing out cookies and tea, and so the community came together. And then they were bombed, and then all the healthcare workers rushed in to help them, and then the healthcare workers were intentionally bombed. And so many of their colleagues were injured and killed. And so that became a topic, not just how do I manage these people clinically, but also how do I deal with the injury of my colleague or the killing of my colleague. Or someone has come and they have taken my family member and they want me to give them a list of all of my patients. And I don't know if I need to do it, because even if I do it, they still might kill the family member, because that's what happened to my friend. And these are complex situations. So about a year or two ago, I thought about the fact that we had covered so many topics and maybe they were recorded, they could just reference them, but I realized that wasn't the meaningful aspect of what we were doing. It was really giving them the ability to communicate and to reach out with somebody else that saw what was happening to them, and that they weren't just forgotten caring for patients in isolation. And so we've continued to do this, and we've de-identified and submitted many of these topics to the United Nations Institute for Training and Research, where they've posted it online after being peer-reviewed. So they are freely accessible. We've had in the last year, about 1,400 people complete these courses, and we've given about 400 certificates of completion for the 5 that we have. But I think that in terms of lived experience, these are experiences that we've all really seen create barriers to clinical care that they will carry with them for the rest of their lives and careers.
Thank you so much to all 3 of you for those really important insights. I've sat in on some of the global trauma collectives, and I'm really struck by how important it is. All the work that all 3 of you are doing is just creating a global community of practice with your peers in the most difficult situations. And I think, there's nothing that, can replace that. And I think we need more of that, because it is just kind of colleagues talking to colleagues. And I think there's a real powerful experience there. Which now brings us to really the next question, which I think some of you already addressed. But it's to really talk about good practices and existing frameworks. And I have individual questions for all of you. And why don't we go ahead and start with you again, Dr. Davis. The UNSCR 2286 called on member states to take concrete steps to protect healthcare in conflict, which we have already talked about. But from your perspective, a surgeon standpoint, what are the barriers that clinicians are experiencing in terms of providing quality of care of patients in the field?
So I think for any resource variable setting, you're already experiencing so many barriers. To have good practice, you need the space, stuff, staff, systems to make your clinical work really functional. So particularly in surgery, you need sterile things. You need water, you need electricity, you need blood banks, you need pain medication, you need nursing staff. And all of these things break down. You might have one and not have the other. I've certainly been in an operating room where we had all of those elements but not instruments, and you can't operate. And so the breakdown of one element, much less the breakdown of many elements, creates these massive problems in being able to handle care effectively. And then you add conflict to it, and suddenly you're not able to necessarily even protect yourself, much less protect your patients. You don't know if someone's going to come into your hospital with a weapon, if your vehicle of transportation is going to be utilized in a way that is not intended. And so certainly all these things are exacerbated.
Great. And Dr. Morrison, we've talked about how surgery sits at the intersection of technical complexity and extreme resource scarcity. Would love to hear from you, what are the practical adaptations or care protocols that have proven most transferable across different conflict environments? But I also want to ask you to kind of go back to something you said that was really important, which is this gap between what you see on the field and the policy conversations and the policy frameworks, which are basically, frankly, inadequate for giving you what you need. So talk to us about that.
To answer the first question, it really actually is more simple. When you're in a resource constrained setting, you just use what you have and you make it work the best that you can. There's a lot of MacGyvering that goes on, understanding the principles of what you're trying to achieve, and instead of using fancy pants, pre-made gadgets to do it, you put together what you have to make it happen. And a lot of surgeons in third world countries over the world have been doing this and are still doing this on a regular basis, and that certainly is true in the field, on the front lines in surgery. And at the end of the day, there are certain basics that you need to have. You need to have some sort of anesthesia so that your patients, you're not basically torturing a patient alive by cutting them open and removing an organ with them awake. You need to have, antibiotics and pain medications and basic sutures, basic surgical instruments and things like that. But it never ceases to amaze me how adaptive physicians and surgeons and nurses can be in the field with limited technology. One of the things I think that's hardest, especially for surgeons coming from countries like the US, where we have so much available technology and infrastructure and help, is we've always taught do the best that you can for the patient, the gold standard for every patient. And here in the US, that's pretty easy, because if one thing fails, you've got 10 million other gadgets. No matter how expensive they are, you just ask for the next expensive gadget and it shows up in your hands and you try that. One of the hardest things for me, especially as a younger surgeon when I was first starting, is learning to accept that lower standard of care. Learning to accept that, God, if this patient was in the US, I would have them out of here in 3 days, but they're not. And I wouldn't necessarily have to amputate this leg, because we would have endovascular, all these fancy words that I'm not going to use, but like all this fancy technology that we have that we don't have there. There, the only answer is amputation or a colostomy. I mean, if you think living with a colostomy is hard in our society, imagine living with a colostomy or an ileostomy in one of those settings, and how hard it is medically to take care of, how demeaning it is to your dignity to be covered in stool all the time. All these things are things that you see that you don't think about until you're in those settings. And just learning to accept that you're doing the best that you can with what you have, and that you're doing the best that you can for the situation. I think that's the harder part. And you do have to kind of accept a different standard of care. RORs are not always sterile. They're clean, but they're not sterile to the standard that they are here. And that means you can't put a metal rod in somebody's femur that's broken and send them home in 5 days. You got to let the bone heal in 6 to 8 weeks. They're stuck in traction for 6 to 8 weeks, in your facility, not moving. Someone's got to feed that patient. Someone's got to toilet that patient. Someone's got to care for that patient. We have very limited nursing supplies. There's a lot. I mean, I could talk forever. There's a whole lecture just about that. As far as the disconnect, I kind of wanted to tie together something that you said too, was especially the unintended impact on civilians of warfare, and the use of certain munitions, which again, I'm a surgeon, I'm trying to stay in my lane and not to get into other policies and military things where I'm not credentialed, but we do see controversial weapons like landmines and cluster bombs, unexploded ordnance, You think, oh, well, that's just a side effect of using them. They're very effective because of X, Y, and Z. And yeah, there might be some civilian casualties, but whatever. Well, I see those civilian casualties. And guess who is the #1 most injured person from a landmine? It is not a soldier. It's not even a working man or an adult woman. It's a child. And I have seen on multiple occasions, they look like little butterflies. Some of them look like little toys. And a child will see it, bring all of his brothers and sisters in there. They're all playing over it, and then it goes off. And a mother has lost all of her children, and maybe the one surviving baby who was behind the smaller children because she couldn't see, she still loses her eyes and her face are permanently disfigured, and she's never going to find a husband or be accepted in her community again. Was it really worth it? What military gain did you get by indiscriminately placing mines and not cleaning them up afterwards? Same thing with unexploded ordnance. The #1 people who are going to be affected by those are farmers, people trying to provide for their family, children. And someone was asking before about research and things like that. And we keep records, and I think probably most people in MSF and other, we keep records of everybody who's injured and what their injuries were and what the weapon was. And when we see things like that, landmines or UXOs, we report those up the chain to ICRC, and there's a UXO expert, and people, it's noted. And how it gets all the way back up to policy and whether that really makes a change, I don't know. But as a surgeon, what I can do is record when that happens and report when that happens and talk to people like you and all over the world to say there's a human face behind every casualty. And anything that we can do to protect civilians, we should. And we can from a policy standpoint.
Thank you. Okay, Dr. Hawk, you recently co-authored the AAP policy statement on the effects of armed conflict on children. Can you talk to us about this policy, the key findings and recommendations?
Yeah, so this was a great opportunity to work within my professional society, the American Academy of Pediatrics, to really address a gap in the policy. And while policy doesn't, do everything, it was really informed by stories from the field and pediatricians who had worked in humanitarian settings. But again, just looking at the scope of this problem globally and its impact on children, 520 million children annually are affected by armed conflicts, but there wasn't a strong policy space to really look at the child through that lens. And so what this policy statement does is it reframes armed conflict as a child health and development crisis. And really looks at the disproportionate harms that children face as direct and indirect consequences of armed conflict. And it really emphasizes that a lot of the harm to children in conflict is not through direct violence, but really the breakdown of systems. So healthcare, education, other social protections for children, and this is all happening during a critical developmental window. And so these breakdowns in the healthcare system, think of a vulnerable neonate, or a child living with medical complexity, or a child with disability. Those are the children that are really going to feel the impact of the breakdown of the health system. And then we can see a ripple effect and kind of lifelong sequela of that breakdown in the health system. And so the policy statement really tries to center that and think more specifically about what we can do with children to protect them in these settings. The policy statement is also really grounded in child-specific normative frameworks. So specifically, it's anchored on the Convention of the Rights of the Child, which really focuses on children as rights holders and that they're entitled to the highest attainable standard of health, even in a conflict. The policy statement also has a big focus on trauma-informed care, which is something that's been really important in pediatrics, but really defining trauma-informed care as the approach to assess and recognize and respond to all of the effects, myriad effects that children are experiencing in conflict. And the policy statement, again, also really highlights that children are fully dependent on the adults and the systems around them, and really focuses on that dependency, that, you know, without focusing on that, we really risk failing children. And then the policy statement also gives pediatricians and pediatric institutions something to stand on to advocate for policy at the state, federal, and global levels that really centers the needs of children. And one of the things that I'm really proud, you know, it seems like the most simple statement, but it's now written into American Academy of Pediatrics policy, that harm to children should never be used as a tool or tactic in war or conflict. And so that seems like the most basic, you know, statement that everybody should agree with. But I think, you know, getting that into written policy is important, and it does help keep the needs of children central.
Thank you. Well, let's talk about getting the basics into policy. Why don't we turn to Dr. Morrison? As we heard from Trevor earlier, the ICRC has developed specific recommendations for militaries and different actors on protecting healthcare. Can you talk about those recommendations based on your experience? What's been operationalized? What remains aspirational? What do you think?
I think there's a lot already existing that was previously discussed in the panel as far as setting pretty clear guidelines. And when it is followed, I think it is helpful. So one of the things everywhere I go with the Red Cross, just like she was saying earlier, everything is clearly marked with a medical Red Cross sign. Like, it is unmistakable. Like, an engineer decided that, like, the Red Cross that we wear on our little vests can be seen from 200 feet. So you can't even say, like, I have bad vision, I couldn't tell that was a Red Cross. Like, it is designed so that someone with 2200 vision can see. I am marked. I am a medical worker. All of our vehicles are marked on all sides. It doesn't matter if you're approaching from the front, the back, the side, or a helicopter overhead. There is a bright Red Cross that is a huge size, again, specifically designed. Like, we go to every effort to identify ourselves as healthcare workers. Like, it's obvious. And the rules say that people who are marked as healthcare workers, locations, vehicles, whatever, are protected. And so I do feel like the onus isn't on, like, we as medical humanitarian organizations do a good job of, like, clearly identifying ourselves as medical. And if someone chooses to attack us or target us, despite that, I mean, that's sort of beyond our control, but, like, control the things you can control. That's one of the things that we do. The no arm sign, and we can be stern, and it's amazing what a little white lady with a lot of attitude can do to a giant man with a gun who insists on bringing it in. You know, at the end of the day, you do have authority as a physician or as a hospital worker, as someone. Like, if you stand with authority and you stand by your principles and you say, no, sir, you're still polite. You cannot enter this facility. I will not allow you to enter this facility. It's amazing that people who are initially, you know, assuming that they can just do whatever they want, they will actually put down their weapons and agree to come into the hospital without their weapons. So I think even just the will and the courage just to say something. People think, oh, it's not going to matter. They're you know, crazy IO. They're not. They're opposition rebel forces. They don't respect rules. Well, did you try? You know, sometimes they do. So I think the not having weapons. I've never had an issue in any of the places where I've been of confronting people and having them leave their weapons at the gate. And then, like Fabrizio said earlier, having really good, trusting relationships with both parties. And I can speak only of my experience in South Sudan, but we did. We were warned by either side whenever the fighting was going to come close to a hospital. They gave us the courtesy of a warning. Hey, the front's moving really fast. We think it'll be there in blank hours. It's probably going to come close to the hospital. Like, get people out of there. Get yourselves out of there. And if we have time, I do have a recording of one of my colleagues who was in a facility that was under target, and he gives about a 5-minute explanation of what exactly happened. But basically, They got the warning that it was imminent. Everyone went home and packed their grab bags, their go bags. They still went back to work and worked in the hospital. When they got warning that it was coming really close, patients had the option of either going off on their own with their families if they were ambulatory, if they were able to walk. If not, the Red Cross helped to evacuate them to some random location in the bush that was far away from where the fighting was going to be. They had these little like dune buggy kind of things, and they transported people back and forth until they got them there. And then eventually, when the fighting was cleared, they were evacuated by Red Cross aircraft. But I think as dramatic of an event that was actually an example of the way it went right. And that was actually people from these, again, certain first world countries like to hold themselves as being, very not savages and not whatever, and like, oh, some of these other countries that are the bad actors, but that was actually an example of the military and the rebel sides both communicating with us according to international humanitarian law and giving us time to get out. Now, was the hospital looted later? Yes, it was. So, it wasn't 100% like everyone was a Boy Scout, but they did respect us as Red Cross members. And they did give us the proper warning to leave and to evacuate, and also the opportunity to evacuate our wounded who were unable to ambulate.
So I think we do want to hear it. What I might do is have you tee it up, and I'm going to go to Dr. Davis and come back to Dr. Hawk, and then we're going to listen to it. Okay. And this is actually a perfect segue to the question I have for Dr. Davis, which is really the impossible choices that health workers actually face in the field. Health workers themselves are increasingly targeted. And so in your experience, and also as you've been doing the Global Trauma Collective, what ethical frameworks or professional codes have proven the most useful in helping clinicians navigate this very decision? Do you stay, do you evacuate, do you treat combatants, do you go, and are those frameworks adequate?
This is actually a question that comes up very often. And so there are frameworks that exist, particularly within our military. So one that's often referenced is the TCCC, or the Tactical Combat Casualty Care Protocol by the military, which gives guidelines for when you would go out and recover someone who's been injured in a situation of active fire versus waiting and providing field care versus evacuating later. And those things are helpful, but they are limited because as healthcare workers, we do have different goals than a military does. And for us, I think one thing that remains at the forefront of my mind when I'm asked this question is that this person is potentially the only clinician in the region. If they become injured in some way, no one is getting health care. So this person, they are the asset. And just like I would recommend to our trainees that they are very valuable and they should not be putting themselves in an area where they could be injured. I think that even in a war setting, you have to the healthcare workers have to take measures to protect themselves. But it's certainly something that they feel very conflicted about. So as medical practitioners, when we go through training, we're taught principles of ethics. So we have the principles of non-maleficence, beneficence, autonomy, justice, and we want to be there for our patients. And they would take a bullet to complete a surgery or to make sure that their patients do well. But in the end, it's not really helpful if they take a bullet. And we had 2 surgeons in Haiti. One of them was coming and got shot by a gang member. The other surgeon then, in addition to the very heavy caseload, was having to manage their partner who'd been shot. And so, you create additional drains on the healthcare system by becoming injured yourself. So it's a little more complex than just, no, I would take a bullet for my patient. You have to also be a little bit savvy about that.
Let's turn briefly to Dr. Hawk, and then we want to listen to the recording. Dr. Hawk, given that your colleagues at the AAP just released this guidance that you spoke about, What has been your strategy to get this elevated in domestic and international policy circles so that it actually becomes effectuated?
Yeah, so I think when we wrote this policy statement for the AAP, we wrote it from the thinking that the policy statement is not the end point, it's actually the beginning. And so it gives us the scaffolding to then do the work of addressing the issues that children in crisis face. And so it really kind of ties together the evidence, the child's rights principles, and ethics into a single authoritative framework that pediatricians and professional societies can use to speak collectively, consistently, and authoritatively about protecting child health. So it sets clear expectations for what that looks like, and really gives us, something that we can hang our hats on and speak about. Second, the policy statement is already driving education and capacity building. So the policy statement is kind of setting the agenda for education and programmatic work. And the AAP does a lot of work with sister professional societies in other countries and other groups that they're working to build pediatric capacity. So just in the last several months, they've done work with the Norwegian Red Cross in Somalia on essential newborn care. So how do we actually make sure that the neonates in this conflict setting are getting the care that they need? Similar neonatal training initiatives in South Sudan, as well as a pediatric emergency, train the trainers in Kuwait to provide providers with pediatric-specific knowledge so that when they're deployed, they're able to serve the needs of children. And then the other thing that we have done is actually stand up a humanitarian pediatrics subcommittee within the American Academy of Pediatrics. And this group is trying to really coalesce all of the experts who have, field experience and expertise in this area to be ready to serve the Academy should needs arise, to plan education and advance a research agenda in this area, to really ensure that the child's specific needs remain front and center. And so, when we wrote the statement, the goal was really that it would just be the starting point. It allows organizations like the AAP to speak out more strongly for children and really center the needs of children in crises.
Thank you. Okay, let's listen if you're ready.
All right, yeah, so this was an interview of one of my colleagues. He was a scrub nurse in Kodok, South Sudan, as fighting was approaching. And I'm just going to hold it up to my microphone. Oh no, of course it's not working. Come on. Hold on.
Thank you so much, Dr. It's so good to hear from you again. And thank you for supporting our ICRC activities as always. The moment you speak about was when we were in South Sudan in the project in Kodok, where at some point we were informed of an impending attack or conflict between the government forces and the opposition forces. And the area we were in at the time was the opposition area. So what happened was a sequence of events, as I recall. At the beginning of the week, we were informed that there's a possibility of an attack happening in that week. Therefore, we were asked to prepare our grab bags, which was 15 to 20 kilograms, to be on the ready at any time should the event happen. So we went to hospital, we did our usual procedures and rounds, and I recall that the air was quite cold, or should I say tense, with the anticipation of what would happen. So we went back to the base, and when we were at the base, we were informed that the stories are still true, that it will happen. And we noticed the mobilization of the community forces, if we may call them that, preparing to go to the front lines. And that evening was uneventful. The following day in the morning, we went to the hospital, and there was some slight behavior of activities. The patients were there, and we reviewed them, and we even thought that maybe we could do one or two smaller procedures as we wait for what would happen next. Then we went back to the base, and when we came back after lunch, the hospital was deserted. And we went back to the base, and the head of the hospital, or rather the head of the base at the time, informed us that it's a go, we must leave immediately. So we took what we had. I remember I drove the golf cart, like buggy, the off-road one, that we went to the hospital with and loaded our mass casualty items. And the rest of the mobile surgical team took the other land cruisers and loaded them up with supplies that we would have needed to move to the location which had been identified, which was called Abroch, which was some 2 hours through the bush. And when we went to the hospital, I recall when we just arrived like this, we received one body from the front line, which was a very young soldier who had died from gunshot wounds. And the locals were preparing to bury the person. And we got what we could from the hospital and started driving as a convoy into the bush towards Abroch, which was mapped for us by the lead vehicle. And as we went on past the airstrip, we started seeing signs of the patients who had left the hospital. Some were on crutches, some were pushing each other on the wheelchairs. And we loaded those who we could onto the vehicles, the most critical who we could see, because some were still on traction. And the others insisted that they will be able to walk for the distance. So we tried to keep them within view as we drove forward. And when we eventually arrived at our destination, it was just starting to be dark. And patients actually all managed to arrive at the site where we were. We did note that the other organizations had arrived, I think, the day before and had set up a place for us. So we set up our tent and spent the night there. Then the next day, ICRC sent 2 planes for us. One was for the patients who were still to go to the opposition areas, and the other was to take the patients who were to go to the capital, Juba, and be admitted in the Juba Military Hospital. So further to that, I think 2 or so weeks later, the ICRC, in coordination with due to our neutrality, was invited back to the hospital by the government forces because they took over the hospital in the Kodok area. Luckily, there was minimal damage to the facility. Anecdotally, my scrubs were still hanging where they were, and our anesthetist
He's too big.
was
No
part
one
of
fit in
the
his scrubs.
forward mission to go and establish more, or rather re-establish the health network there, managed to bring them back to me. So I still treasure those scrubs for surviving, if I may call it that. So that's my memory of that. It's not really a healthcare. I'd say it is healthcare in danger because we had to evacuate the hospital, and the patients were left quite desperate, if I may say so. But the facility remained quite intact, and were able to bring patients to be seen back there later on. Although I wasn't part of that team that continued to be active there. But that's more or less what happened. Thank you.
Wow. So I'm going to throw you a curveball, a question that
She's looking at you. I know.
you all haven't prepared for, but I think it's important, and if you're willing to answer it, I think I'd appreciate it, because it's been kind of running through my mind since we started this morning, and I think. So I'm gonna basically break the script, y'all.
I love it.
So we started off this morning, and I think Fabrizio used a phrase which is important, and it's definitely the way that I have tried to sort of approach my job over whatever the last 20 years, and you all are trained in the same way. And Fabrizio used the term of basically having to maintain a certain level of dispassionate professional distance so you can actually do your job. And whether you're ICRC and trying to apply law of armed conflict, or IHL, or if you're Ambassador Satterfield trying to negotiate complex Middle East crisis, or if you're me who has to pick herself off the floor after Kundus was bombed and write talking points for the president, Or if you're you and you're treating children, or you're treating landmine cases, or you're treating surgical trauma. But at the end of the day, all of us, there's humans and there's people behind it. And I, for one, struggle with that professional distancing and that dispassionate analysis that I believe I've been required to do in my job. In fact, I've gotten choked up a few times, like just listening to y'all talk. So I want to ask you, how do you deal with that? And maybe if it comes to your mind, tell us the story of the patient that you're not going to forget, the case you're not going to forget, because I think you obviously need it to be professional and somewhat dispassionate to successfully treat your patient, or for me to successfully help negotiate a crisis or kind of work through, whether it's a global health or humanitarian crisis. But at the same time, there are people and children and people that we're not going to forget. And just like the voice of your colleague just now, to make it real. So if you're so inclined, sorry to throw you all a curveball, but I think it's an important one. To go ahead and answer. Tell us your story. Who wants to go first?
I could start. There's obviously violence in many parts of the world. There's violence in our own community. And so I think that I realized that in training, one of the ways that I was trying to cope with managing these very challenging, traumatic injuries was becoming very dispassionate. And probably 5 or 6 years ago, I very intentionally realized that those are the parts of myself that I like. I like being empathetic, and I don't want to have to disconnect to treat patients well. And so I think making changes so that you can continue to be empathetic, and that's an important part, and understanding ourselves and having time to reflect is so important. And one patient that I think pushed me toward thinking about that was we had a patient who came in and he had shot his wife in front of his child, and then shot himself, and it's just a hard thing. So, but I realized that the fact that I can continue to be empathetic about that is that's important, and it's worth continuing to engage, even though it's challenging. So yeah, that's what I learned in my career so far.
And for you too, the fact that you have that ability to communicate with other surgeons who are so isolated, and to be just a sounding board, just to be a caring, empathetic ear, I think that's a huge service. For me, one of the cases that will stick with me forever was in South Sudan. There were 2 sisters. They were probably in their early 20s. They both had young children, probably about 1-year-old each, both still breastfeeding. And they were trying to escape their village in a hurry. One of them had their baby strapped across their front to breastfeed. The other one had her baby on her back, strapped to them, and they were running. And they got shot by, again, AK-47s, very indiscriminate. Even people who are well-trained in how to shoot and aim, but much less a lot of these troops do not have proper, the whole point of a rapid fire machine gun is that it does as much damage as possible in as little time as possible by someone who is as unskilled as possible. And that day, that weapon achieved its purpose. It hit both sisters multiple times. The one with the baby on her breast, the baby absorbed the vast majority of the high energy velocity bullets. It was killed instantly, pretty much its head exploded. But the bullets lost velocity as they were traveling through the child's skull. So by the time it hit the mother in the chest and the arm, the velocity had slowed enough that it didn't kill the mother, it just caused very severe damage. We put chest tubes in her, it went through her axillary artery and cut off the blood supply to her arm, and by the time she got to us, her arm was gangrenous, so we had to amputate her left arm. But she lost her baby in front of her, and she carried her deformed baby with her all the way to the hospital, and of course there was nothing we could do for it. Her sister was killed. The bullets went through her chest, but because it went through her chest, she absorbed the impact of the velocity, and her baby, there was 2 bullets lodged in the baby. One was in its chest, and one was in its liver. And the baby was alive when we got her. So the sister, who had lost her own baby, and her sister, picked up her niece, and she walked, I don't even know how far, to the hospital, or to somewhere to get aid to come to our hospital. And we were able to save her niece. But that was just, how much trauma can one person go through in one day? And they did nothing. They were fleeing. They were clearly not a target. And that one person who probably just, that wasn't necessarily their intent. You know, like they were there like just to get control of the village. Their intent wasn't necessarily to murder a baby and a young woman who was nursing. But that's what happened. Because there was indiscriminate violence. That's why there's rules of war. And again, touching on the point that we're the ones who see this on the ground. You don't see that. You just see casualties. 2 civilians killed is what you see on paper, and you don't see the reality of it. And as a surgeon, and Rachel alluded to this, we're kind of eased. We see a lot of crazy stuff, but we're kind of eased to it. We go to medical school. The first time you see a dead body, it's like an old person who'd reached the end of their life, and it's still shocking to see a dead body, but you see things over time, and you watch your attendings talk to the family. You watch someone more experienced than you have these conversations with the family. We have to tell them that their 19-year-old son was killed, in a car crash or whatever, and you watch someone else do these difficult conversations and how empathetic they can be, and you learn in the operating room that you have to shut it off. It's an arm, it's a leg, it's a liver, it's a spleen. It's not a human, it's not a person. To get through those moments, you have to separate yourself from the humanity for a brief moment in order to do the unthinkable job, which is like opening up a human body and trying to put it back together again. So there definitely is some dissociation, and a lot of times for an entire shift, I'll just put it back in the back of my mind, and you don't deal with it, but you have to deal with it at some point. And so having open conversations, having someone to discuss it with is important. And another thing that I just wanted to say while I have the platform here and an audience is, healthcare is dangerous, and healthcare in these settings is dangerous. So why do we keep doing it? And why is there a need for it? And why is it so special that it has to be protected? And going back to pediatrics and children, Mr. Rogers is very famous for this quote that he said. Someone once asked, how do you tell a child who has witnessed something traumatic, how do you help them get through that and cope with that and not be paralyzed by the traumatic thing that they just visioned? And he said, tell them not to look at the carnage. Tell them not to look at the gore and the disaster and whatever has happened, because that's what, as humans, that's what attracts our eyes. The sensational, disgusting carnage of it all is what attracts our vision. Stop looking at that. That's not what's important. Look for the helpers. Everywhere there is a disaster, everywhere there is trouble, people are going to start coming out to help. Look at the helpers, look for the helpers, and follow the helpers. And that's what we are as healthcare workers, physicians, nurses, physiotherapists on the front lines. We're the helpers. I think at the first panel, someone said, this is a crisis of values. And it is. As long as there's war, and humans are humans, there's going to be certain humans amongst us who just want to inflict suffering. And I don't know that I can stop that, or that anyone can stop that. But you know what I can do? When that suffering happens, I can be there, and I can do whatever I can, my part, to alleviate that suffering. And there's going to be people like us, too. For every person out there who wants to inflict harm, who wants to violate humanitarian law, who wants to target healthcare workers or civilians or whatever, cause damage, cause suffering, it all comes down to values, and I refuse to let that happen and not do something. And I hope that I inspire, I hope there's students out here listening who are inspired that, yeah, it's getting worse, and the means we have of inflicting harm on each other is growing exponentially with technology. We're coming up with more and more ways to inflict more and more pain and more suffering on more people, and there are some people who are using that technology for that purpose. But we have a response. We can respond in whatever way we can, and part of that is inspiring others to not be afraid, to stand up, to do the right thing, and part of it is to respond in whatever ways we can. People ask if I'm afraid, if I would stop doing ICRC work because it's dangerous, because I'm going to a war zone and I could be targeted. And my response is, I make every effort to mitigate the risk to myself. I work with the Red Cross, which is one of the most responsible organizations in terms of not putting their people in harm's way, of having buy-in from the hostile parties involved to be there in their support and protection. And if we go through all of those efforts, like we really make every effort to identify ourselves as protected people, and somebody chooses to go against humanitarian law and just shoot me, like, I mean, that's on them. That's between them and whatever higher power they answer to. I know that I have a responsibility to step in and to do the right thing no matter what. And me saying, oh, but I might get hurt or I might be in danger is not a good enough excuse to not follow Mr. Rogers' advice and be the helper where I'm needed.
Dr. Hawk.
Yeah, I thank you for sharing all of those stories. I really don't have too much to add to that. I mean, such powerful stories that we've just heard. Only to offer that, you know, witnessing the death of a child is something that's extremely difficult. And when you witness the death of a child, you know, not because the technology or the medicine doesn't exist, but because of their geography and where they happen to be born, that's something that can really just stick with you forever. I work with a lot of trainees. I direct our global health residency program, and so work with a lot of young, motivated doctors who want to go out and change the world, and you know, watch them come back from the work that they've done in resource-limited settings, and you know, sometimes they come back really broken from the hard things that they've seen with children, again, really just because of geography and access. And so, you know, working with them to reframe that pain and turn it into purpose, to keep going, to work on influencing change through the means that we have, and just trying to carry those stories forward and do more good in the world.
Thank you. That's a perfect segue to our next question, which is, I have all these long words on how to say this, but very simply put, to the students out there, whether they're policy or medical or just whoever who want to grow up to be just like you, what advice do you have for them? Dr. Davis.
I think you don't have to see somebody to be able to do the thing that you care about doing. For me, there wasn't necessarily somebody with my exact career that I wanted to pursue, and I think just taking those things that you care about and figuring out how to become the best trained version of that, you can make it happen, I think, with the right support.
I echo everything that she said. Just because there's never going to be anyone just like you. You're going to find mentors and people who inspire you. You're going to take little pieces from them, but you're going to make your own way forward, and you're going to find the own thing that you're going to do. And I am a believer that we all have a purpose here on this planet, on this universe, and you have one too. And that thing inside that compels you, that thing that you really feel like you need to do, listen to that. And guess what? The universe will provide. It's crazy how I could tell you my life story, how I end up where I am. And people are like, that's just a crazy coincidence after crazy coincidence after crazy coincidence. No, it's not. I felt very strongly that I needed to do something. I worked hard at it, and the people I needed to help me get along that path just miraculously appeared. And the same will happen to you. If you know what your purpose is, or even if you don't, but you feel pulled in some direction, just follow that string. Follow that string, and it will lead you where you need to go, and the people who need to guide you there will be there along the way. And just don't give up. And don't listen to what people say you should. They don't know. You know in your heart what you're meant to do, and I say just do it, follow it, and don't give up.
Yeah, I think so often in global health, we are really kind of carving our own pathway. There's not always a well-trodden path to do what we want to do, but what I encourage trainees, even if there's no one out there doing exactly what you want to do and what you feel your purpose is, talk to people like these individuals right here. Go seek them out and ask them about their career path. How did you get here? and just be really open to the networking and mentorship piece. I think a lot of trainees are a little bit shy to do that, but don't be afraid to go find somebody that you admire. And then what you do is you kind of patch them all together. So maybe there's no one person doing what you want to do, but you take a little bit of this person and a little bit of that person, and you weave it all together into your own quilt.
That's great. Okay, questions from the audience. That was an incredible session, but I'd really love to hear from folks your questions, thoughts, reflections. Who would like to go first? Wow, everyone's really quiet. That
We're
was an
hungry.
intense
Maybe they're just
session.
hungry.
Oh, do I see someone in the back? Hi, come on up. I think there's a mic here floating around somewhere.
So I have a few questions. Thank you all for sharing your stories and some words of encouragement to students. I think I remember your story about your colleague who I guess had to transport these patients into the woods, and I just wanted to know what is, and you also mentioned justice and rights and ethics, and I wanted to know at one point do you leave your patient, or do you leave, let's say, a group of patients to preserve the life of other patients or yourself in order to give more care?
That's a situational, there's no one answer to that question. Dr. Davis did a very good job, and I have a little presentation that I give sometimes to medical students and residents in training that, you're the only you. And if you're the only doctor providing care to others, in certain situations it does make sense. I think it's a matter of greatest good for the greatest number. And, again, taking risks I think is inherent, but don't take unnecessary risks, and doing everything that you can to mitigate risk. But I think that's a difficult question. I think it's something that we all grapple. I personally have never been threatened with a gun to stop operating on a patient. It's hard to say what anyone would do in that kind of situation, but I think it's definitely an ethical dilemma for a lot of surgeons who have pledged to do everything possible for our patients. And it's like the ethical story where you have like one person on one railroad track and 5 people on the other. What do you do? I think it's a hard, unanswerable question, and that we have to just do our best to do the best for the most good.
There was a patient who was on a ventilator, and a hospital was bombed, and they didn't have electricity, and they had to handbag the patient to provide breaths. And so they had a staff member handbagging this patient. And this came up. This was a question. How long do we have one staff member taking care of this one patient? And I don't know. I don't know the answer, and I don't know the situation, just as she said, but I do think that's unfortunate for basically everyone there, because somebody had to make that choice to stop bagging, or had to make that choice to forgo caring for other patients. And it's just a tragedy. And I think that instead of focusing on, I let that patient die, or I didn't care for these other patients, I think we really need to focus on, why was that hospital bombed? And come back to the things that are causing these structural issues that put healthcare workers in this position to make these impossible choices, and do what we can to say, we can't keep bombing hospitals and overlooking this. This is a major problem for everyone.
Thank you. Other questions, comments, reflections?
The people that are perpetrating these wars or these conflicts, if the communities cared more about the people's health, and the people who were wounded or who have other medical, should there be more security at these hospitals, at these transport units? Should you have You're smiling like that's not a possibility or something. Of course you thought of those things, but have the people that are in charge, are they willing to put forth the effort to provide more security at the different health facilities?
I can only speak to my experience, but in my experience, they already are. They're doing everything they can, and I don't think, one thing that the Red Cross and I believe MSF also agrees is that we don't believe that adding more guns to the situation for defense is helpful. We have ridiculous amounts of passive security and precautions and risk mitigation. Like, we are doing everything we can, and we are. And I hate to kind of make this kind of analogy, but I'm going to make it anyway because no one's stopping me. I'm just going to keep talking. But it's like, at the end of the day, even if we weren't doing everything we possibly could, it's like saying, oh, well, it's your fault you got raped because you were wearing a short skirt, or you were staying out at night, or you were drinking alcohol. No, it's the rapist's fault for raping in the first place. And it's the people who are targeting hospitals. And like, we can take all these measures that we can. We can negotiate with the people at the front door who are trying to bring weapons in, but I shouldn't have to. Because the real problem isn't that we aren't doing enough to protect ourselves. The real problem is that we are being targeted in the first place. And I think most organizations, especially the big ones like MSF and ICRC, take the responsibility of safety for their workers and their patients extraordinarily seriously, and they dedicate above and beyond what should be expected of them to protect themselves and their colleagues and their patients. They take on that burden, and they shouldn't even have to, but they do, because it matters. Obviously, protecting healthcare matters. It matters. But in my mind, it's putting the blame on the wrong place, and it's putting the use of resources on the wrong person. The community, like the governments. Yeah, they should. They should care enough that they should. They absolutely should. Yeah. Got it. No. Message received. Yeah, and I think they should. I think it's their community. Like, we as humanitarians coming into another country, we are outsiders. It's their community. It's their land. It's their people. And if they should care more about the well-being of their citizens than about the political aims and or financial aims of their military combat.
Okay, we have another question. I think we'll just take one or two more, and then so I don't keep y'all from lunch and virtual reality.
There are wars, and there always will be wars.
I know.
The world is on fire. A couple of you are heroes and doing remarkable things, and this world needs as many heroes as we can get. But you don't get overwhelmed when a patient dies. You move on to the next one. That patient's death is not your failure. You did the best you could. You're on to the next one. And whatever we can do, whatever you can do, don't be overwhelmed by the fact the world is on fire. One pair of gloves can save a life. Do whatever you can. Thank all of you for your amazing work.
Anyone else? Oh, I see one over there.
This has been absolutely powerful, so much gratitude. In my line of work, I keep thinking, which is different, it's in the area of energy and climate, but I keep thinking, like, what are some of the root causes to everything that we see? And to Dr. Morrison's point about seeing people at the most basic human state, and you get into the level of actual anatomy by slicing people open. And what have you discovered about the core basics of humanity, that is giving rise to all of this as you navigate all these situations that I can't even imagine what it must be like? But what have you discovered, and what might it help us learn to kind of apply to other fields? That's one part of the question. And the second part of the question is, physicians and surgeons and healthcare people are amongst the most respected across the globe. What more can you be doing to also help reduce conflict, if there's anything at all? Thank you.
Okay, they're looking at me.
Whoever wants to
My
go.
answer is very esoteric, but it's kind of an esoteric question. I think that in what we do, we're faced with the fact that every day people can make poor choices. They can do harmful things to each other. And it's very easy to internalize that and become very angry or very hurt or broken. And in the end, it's not helpful to anyone. And so I think what I feel for myself, and everybody has to handle this in different ways, but for myself, I want to take all those things, and the only thing that I find that's productive to give back is love. And so no matter what somebody's doing to somebody, no matter what they're saying, giving back love through the way that we care for them, I think is the only thing truly productive that we can really do.
And I will echo what she said, getting angry. Darkness cannot overcome darkness, only light can do that. And darkness cannot exist in the presence of light. And all you can do is shed light and shed kindness. And do I ever get angry and do I ever cuss people out and get mad? Do I lose my shit sometimes? Yes, I do. Nobody's perfect, not even doctors. Surprise, I know, sometimes wrong, never in doubt. But I do believe that is the core issue. And when you see a patient, I've seen so many, everybody, even children, old people, everyone across the planet, we're all really the same. We're all way more alike than we are different. And as much as certain ones of us like to project power and arrogance and superiority, we are all very vulnerable, fragile little bodies. And when you are, again, like I think I said, I don't know if I said it out loud or to someone else when I was talking, when they are naked, asleep, and completely vulnerable on your operating table, everybody is exactly the same. And when a bullet tears through flesh, it tears through everybody's flesh exactly the same. We are all made of the same stuff. We are all more alike than not. And who you want to call your enemy could change from day to day, but it doesn't change our humanity. And I think, as I said earlier, it's like, I don't think people are going to stop hurting themselves anytime soon. So what can we do? We can go out there and we can be the helpers, we can be the light, and we can grab people by the hands who are willing to come with us and encourage them to shine their light too. And eventually the light will overcome, or at least overpower, the darkness. Not that we can ever get rid of it, but that's what we can do.
And I'll just offer, there's this concept in humanitarian practice called témoignage, which refers to bearing witness. And so we can all bear witness to these atrocities. And whether you're bearing witness directly on the front lines or bearing witness right here in Houston, watching these atrocities unfold from afar, we can speak truth to what's happening. And I think it's something that all of us as physicians, because we do have that respected voice as physicians, we can use our voice as physicians to bear witness and speak truth to what's happening.
I'll just say, I'll answer the question, but then also just maybe cap off and we can then break. Yeah, I mean, when you asked the question, I was kind of thinking about it, the same exact phrases came to mind, which is, be the light, be the love, which is an odd thing for me to be saying because, again, like if you're kind of trained in US government policy circles, you really just don't talk like that. Like you just don't. But I think there's something very powerful in that very simple sentiment, because at the core that's who we all aspire to be and who we are. I think just in terms of just recapping very quickly, American foreign policy does respond to the values of its citizens. So while, we have, our doctors and humanitarian workers and people who are on the front lines who are in it, I would say that it's really important for all of you or anyone who's listening in the community to, speak your values and speak your truth and have it be heard. Across administrations, I've seen it. I've worked across multiple administrations. The foreign policy does aspire to be a reflection of who we are, and I do believe, we can be better in this space of the rules of war and humanitarian laws and humanitarian values. And I think everyone can find ways to reflect this in your own way. So I'll just ask you to do that in however way you possibly can. And really thank you for being with us all morning long for this, at times, very heavy conversation, but I think it's a really important one, given where we are in time and space. So thank you. Lunch is outside.